Good morning, good afternoon, good evening, and good night, friends and colleagues from across the world. Welcome to the American Academy of Oral Surgery 2020 Global Summit. The Academy was built on principles of education, knowledge sharing, and enabling dental professionals to better be equipped to provide office-based oral surgery procedures to their patients. We understand that oral surgery is a field of study and a discipline of many in the profession of dentistry. There are over 2 million undertrained licensed dental professionals and over 3 billion underserved patients worldwide. Oral surgery is there not just for any specific specialist, but for all licensed dental professionals who wish to learn more and perform these procedures. In the United States, licensed dental professionals are regulated by state dental boards. Dental associations and special interest groups have no legislative or regulatory privileges to prevent licensed dental professionals from performing oral surgical procedures. It's about knowledge, experience, training to keep our patients safe and happy. Let's find ways to minimize the effect of this silent epidemic together by maximizing information exchange and enabling our colleagues to provide better services for their patients worldwide. We will be airing the 21 academic sessions on Facebook's Global Summits page. Simply visit the page at Global Summits, and the live session will be pinned to the top of the page. Click in and you will have access to the presentations, which are complimentary to watch. At the end of each hour session, there will be a link in the comments section that you can fill out to register for CE credits. The link will disappear after approximately 30 minutes. There's a nominal fee for receiving a CE certificate of attendance, but the sessions are complimentary to watch. Today, you will be able to meet certain license requirements pertaining infection control, OSHA, and HIPAA with our pre-symposium virtual workshop starting at 1 p.m. Pacific Standard Time now. And you will also learn about the latest COVID-19 precautions. You will be able to earn up to 24 CEs total by registering when the courses are live. 4 CE units will be attainable today. Tomorrow, we will kick off the general session with our keynote speaker and will be live all day between 7 a.m. and 6 p.m. Pacific Standard Time. And also tomorrow, we will kick off the general session with our keynote speaker and we will be live all day between 7 a.m. and 6 p.m. Pacific Standard Time. 10 CE units will be attainable tomorrow. On Sunday, we will be live again at 6:30 a.m. to 6 p.m. Pacific Standard Time. Another 10 CE units will be attainable. As a token of appreciation for you getting more involved with oral surgical procedures and are expanding your existing knowledge, we will extend a 1-year membership in the Academy valued at $500 and a 1-year membership in Dentulu, the revolutionary teledentistry marketplace valued at $2,500 complimentary. Simply use the code Global Summits on aa-os.org or dentulu.com when registering to redeem this offer. Thank you, and let's have a great Global Summit together, as we like to say, doctor to doctor. With that said, let's commence the pre-symposium virtual workshop. Thank you.
Okay. Hi, everybody. This is Dr. Pattaya. I'm a retired professor, spent about 30 years in dental safety. So let's talk a little bit about who I am, who we are, and how we've associated with the Global Summit through AAOS. Okay, today we'll be talking about 4 different aspects of dental safety. It ranges all the way from today's epidemic, pandemic worldwide. You know, I've provided close to about 40 lectures since March on COVID and infection control for large groups across the globe. We'll talk a little bit about the COVID precautions, Initially we said, oh yeah, in 3 months it'll disappear, right? It didn't. In and out of COVID, so I had planned it. What do we do during COVID? What do we do after the pandemic has subsided and everything has gotten back to normal? But I look at it as the second quarter of next year when we'll be talking about normal, like the past normal. Then I'll bring up a little bit, one chapter on infection control, because I have my infection control lectures go up to 14 hours, for a classroom session. So we do it over multiple times. But I'll talk about instrument reprocessing and sterilization monitoring as a topic. Then I'll give you an overview of HIPAA, which will also include the Texas House Bill 300 for people registering from Texas because they have to cover that as well. Then in OSHA, of the 4 or 5 topics I speak about, I'll talk about the newbie, the new kid on the block, the conversion of hazard communication systems of handling chemicals in your workplace to it's actually moved on to the globally harmonized systems of labeling and understanding labeling. Okay, let me talk a little bit about Tooth CE. Tooth CE LLC is a dental safety educational company, period. We concentrate on the safety issues of the patients, the safety issues of employees, and we also talk about HIPAA. So um, we are not affiliated to any companies or in dental industry with funds us. You guys fund us when you take our programs. So we are servants to you and we provide you good education, solid evidence-based education, which nobody else provides in the country, who's a private company. Okay. And our expertise, as I said, is in dental safety. Okay. And you can visit us at toothce.com. If you have any questions, you are more than free to email me at Dr Pattaya at toothce.com. And pretty soon I'll get back to you. I never leave any messages, unreplied. Okay. So basically we concentrate on infection control, OSHA, and HIPAA. So visit the site, take an opportunity anytime and visit the site, toothce.com. Okay. So let me talk a little bit about myself. Well, I was born and brought up initially in the southern part of India. I grew up in Bangalore. I was born in the Western Ghats, or the areas of the coffee estates on the western mountains of the southern part of India, which is about 3,000 to 4,000 feet above sea level. Beautiful tropical atmosphere and a very temperate climate, though. Okay. I did my dentistry in India at the University of Mysore. Then I joined, private practice, did it for a little while, but at the same time, my concentration was more so on school health programs. I had a huge bevy of uh, regular schools, grade schools, where they needed children to be screened and also a report to be given, a copy to the school, a copy to the parent, and one copy for ourselves, and follow up the kids' care. We never provided care, but we said you can go to anybody else. These are the needs of the kids. And by that, we actually improved the oral health access, availability, and the status by almost 20% among those kids. Okay. Soon after, I joined the Indian Council of Medical Research as a research officer, which is similar to NIH, as a program officer, on a very large oral cancer project where I had to personally screen 30,000 people in 72 villages, everybody from A to Z in each village. Okay. And this was for oral precancers and oral cancers. And I had a huge team of about 15 people who worked with me. They were from different fields of business, rural development, economics, finance, business management, and and planning of health programs. And they all worked with me on that. After spending 3 years in that position, I decided I needed more training in quantitative sciences. I was a well-trained dentist. What I learned to extract a third molar, a fully submerged third molar in bone, um, you know, 35 years ago, I could do the same thing, last year, you know, under local anesthetics. So my training was okay in dentistry. My diagnostic skills for oral cancers and precancers was okay, but I could not understand the numbers. So I decided to come to the US, get a degree in epidemiology, and head back to the cancer center. Well, came here, got a degree in epidemiology, master's in public health. Then, since I was a dentist, they said, why don't you also do an extra track in dental public health? That'll get you, qualified as a public health dentist. I said, sure. And then they said, since you've done this thing, why don't you finish your residency in dental public health? So I said, okay, let me do that. So I spent 4 years in Birmingham, Alabama, getting my master's and my residency done. And soon after, there was, uh, one of my mentors, my future mentors of that time, Dr. James Catton. He had uh, he had an fellowship program in infectious diseases control in dentistry that was funded by a non-rider grant or a focus giving grant by Johnson and Johnson Incorporated. So I spent the next 4 years understanding infectious diseases, patient safety, employee safety. I actually treated HIV patients, full-blown AIDS patients with, you know, tuberculosis. Later, we got to know that some of them were multi-drug resistant tuberculosis cases too. When people would not touch these patients, I used to spend 2 days at the Grayson Street Clinic in San Antonio, you know, treating these patients. And the rest of the time, I spent time in research and applying everything I knew in quantitative sciences. I was, as you can call it, uh, you know, Shula the epidemiologist at that time. Okay. Then after the fellowship, I said, let me go ahead and join a faculty position. I didn't want to go back to India because the program which I was working on was shut down already. So I said, next best thing is to get into teaching. So I was licensed. I was uh, cleared for a license to practice in Texas since 1992. If I wanted to, but I chose the academic track. Joined as a tenure track professor, assistant professor at Texas A&M College of Dentistry. At that time, it was referred to as Baylor College of Dentistry. I was in the Department of Diagnostic Sciences, and then I retired last year as a fully tenured professor. I took early retirement, and I wanted to go into the private sector to teach, develop my company, Tooth CE LLC, and teach. I published over 90 articles, including peer-reviewed papers, over 30 or 40 peer-reviewed papers. I've provided over 300, CE programs within the U.S. and outside. And I've been an ad hoc reviewer for JADA, for Journal of Dental Education, and I'm an editor at large for a few journals. All of them are PubMed listed journals. I've been a recipient of multiple NIH SPIR grants, 3 phase 1s and 2 phase 2s, and a whole line of industry grants through the university. Then I've also served as a reviewer for HRSA and PCORI grants, and I served till last a couple of months ago for about 4 or 5 years as the International College of Dentists Dental Safety Programs scientific director, where I traveled around the world lecturing to the inductees of the ICD to be the future trainers in infection control. And now, I have a small company which I do in-office trainings or on Zoom, and as well as that's called oshafordental.com. And I also have a company called Tooth CE LLC. And that's about me. Okay. So today's topic, COVID, infection control, HIPAA, and OSHA. How we're going to handle this is I'm going to talk to you guys for about 45 minutes on the topic, and then about 15 minutes for question and answers, and I hope the moderators can actually tell me what the questions are, and then I can answer those things. Okay? Now, I'm sure all of you uh, can see this slide. There are resources which I follow. I just don't follow what comes on social media, although I dabble in social media, trying to tamp down all kinds of misinformation. But all my material come from federal and superior organizational sources. Like, for example, I look at CIDRAP, Center for Infectious Diseases Research and Policy of the University of Minnesota. They are some of the finest epidemiologists in infectious diseases and in antimicrobial resistance stewardship. Of course, you must have heard of Dr. Michael Osterholm, and I've been following him for multiple years, for almost 25 years. Then I look at the Centers for Disease Control for the United States. I look at the WHO for their resources for the rest of the world where it may not apply to the US. Then I also look at, OSHA for the US, because OSHA is for the US and US territorial areas for employee safety. But by and large, all these sources give the same common principles and concepts in infection control and occupational safety. Okay, I want you to download these resources. You can go to the OSHA site, the new guidance on COVID. That's one. You can go to the Centers for Disease Control. All the ones on the right side are the hyperlinks. You can actually click on them. I don't know what format you will get these as in handouts, but if we can PDF it and send it to you guys, you can click on these and you can get those uh, links and you can actually download those materials. You don't keep it with yourselves. Then the American Dental Association, they have some really fine resources on how to screen and a patient before you let the patient enter, how to manage your own personal, screen your own personal at least once a day, to see that you guys are not feeling unwell and have picked up COVID. Okay. So there are, then apart from that, you got to also look at your own state's regulations. Sometimes, see, COVID is not affecting the United States or any one country in a monolithic fashion. Each country is divided into different populations, different concentrations of populations. In some places it goes up, in some places it comes down. Then a couple of months later, it will flip itself. So you have to look at your own local resources and the disease rates, the hospitalization rates, before you just open your practice. You got to actually listen to the local news, which is very pertinent towards safety. So now there's a big, hypothetical question I put out here. Are current infection control protocols acceptable for the future? I would say no, although we've done a lot in the past 9 months. Okay. Basically, if you look at infection control training in dental schools, it's pathetic. I've taught infection control for 30 years. You're competing with other subjects. Implantology, yeah, it's bigger. Oh, it earns more money. Infection control, nah, infections don't happen. That's the thing. Understanding the concepts of an infection, contamination to an infection, to a disease, towards disability or death, all those concepts are not taught or even wanted to be understood. Okay. This is because of the responsibility or lack of thereof in the leadership in dentistry. They put infection control till 2019, infection control was under the rugs. Now, all of a sudden, this new disease comes up and everybody says, oh, let's go, let's go, let's go. They read more social media, Facebook, Instagram, all those kinds of things, and try to acquire information rather than going to credible sources. Okay. Dentists are not following basic principles in dental infection control and safety. I can vouch for that. On an annual basis, I at least visit 60 to 80 dental clinics. And I look at it, I do a walkthrough, I show them where they're lacking. Okay. Most of the education you guys seek You want it for free. There's a rep from a dental company who will come and talk about infection control for about an hour, and then they'll sell you a whole bunch of products for free. I mean, the education is free, but you buy the products. Most of their information is based on their products rather than on the substance of the subject. Okay. All of a sudden, in 2019, I didn't see so many experts in infection control. 2020 comes up. All of a sudden, a person with a computer or a tablet and a Facebook account becomes an expert in COVID. And they fight you to the tooth on their understanding of the knowledge out there. And some of these people also provide CE because the companies or the organizations that clear CE, they really don't look into every single topic, the content of the topic, and who's providing it. Okay. State boards, OSHA organizations are not doing enough proactively. Only when some big scandal happens, like in Tulsa, Oklahoma, where the oral surgeon infected a bunch of people with hepatitis, with HIV or infectious diseases, and then there were 2 index cases of Hep C. Only then it all blows up, it hits the fan and everybody runs scurrying around. But if you do it proactively, there's more importance towards infection control. Now, protocols are written as a consensus by organizations, not by experts. They may be an expert in the field of epidemiology. They may be an expert in the field of infection control. They may be an expert in the field of policy. But is there one person with 30 years of experience who can put those things together? No. So they come to a mediocre agreement and they call it guidelines till they understand the disease even further. Okay. So it's sometimes not science-based. Although they may say it's evidence-based, does it translate into applicable science or practice? Those are some of the things which we need to think about. Are current infection control protocols acceptable for the future? Not really. We are still in the middle of this pandemic. And we still have everything, right from your personal, thoughts all the way to politics. Okay? All these things impact how we practice. Some states say that, oh, mask is mandatory. Some states say the mask is not mandatory. But are they really looking at the disease levels in the community? It doesn't have to be a statewide thing. For example, take in Texas. Till today, we were pretty good. In the past few weeks, we have the highest number of cases. And it's concentrated where? In El Paso, the southwest of Texas, in Houston. Now it's creeping into even Murphy, Texas, which is in Collin County, which used to be very quiet. Okay? So these are some of these things we got to think about. Okay? Most of the stuff which is being published by the organizations, the CDC, the CIDRAP, the WHO, all of them are more of a guidance because we are still trying to identify what are the risks, and more so towards dentistry. Dentistry is a very different field. It's a highly surgical field, and our exposure is very high. We work within 1 foot radius of the mouth. Okay. So they come up with a guidance which will go into a public, what you call response later, and it might become a federal rule, or a recommendation by the CDC. So basically, you got to take the necessary action to control recognized hazards to reduce harm to the patients as well as the employees. Okay. So let's talk a little bit about SARS. Okay. SARS-CoV-2. It's also the disease is referred to as COVID-19. It originated in Wuhan, China. Everybody's still talking about how could it originate there, or was it cooked up by humans and stuff like that. I leave that to the powers that be, but I talk about the safety part. It became an epidemic in China, and now it's a pandemic worldwide, and we're still dealing with it. Okay. So we have to think about the exposure risks, the sources of exposure, routes unique to COVID-19 transmission. You got to think about today's guidelines may change tomorrow. You have to adapt to the newest guidelines. That means you have to keep up with the knowledge with these good organizations that are putting out information. So train your workers based on the risks of exposure and the current guidelines, and you'll do the best as anybody could today. Is infection control dictated by epidemics? Yes. Today we are facing COVID. You know, we had SARS in 2003. We had H1N1 influenza in 2009. We had MERS later, 2011, 2012. Influenza, it's an ongoing thing. All these have actually fortified a concept called additional precautions or transmission based precautions based on the type of disease and how it is transmitted. For blood and other body fluids, the universal precautions or standard precautions were written to control bloodborne pathogens. But when we are hit by other avian or airborne strains, I'm sorry, not avian, airborne strains that can cause the disease, then we have to lift ourselves up and follow those additional or transmission based precautions. Okay. Some people try to rewrite universal precautions into additional precautions, and that's not a really good idea to follow. So many of these diseases have actually improved infection control, not on a consistent basis, but like sporadic stuff we add on. Okay. If you look at the history of epidemics and pandemics, you know, 400 BC, we had the plague of Athens, where it killed thousands of people. 165 to 180 AD, the Antonine plague. Then came the plague of Justinian, the Black Death or the bubonic plague. Then in early 16th century, we had smallpox and measles worldwide. Okay, not in the New World, but in the Old World. And then they transmitted it into the New World when the Americas were discovered by the Europeans. So it's the disease of the Old World which we spread on purpose or inadvertently. It happened. Cholera, Spanish flu. We all talk about Spanish flu. Spanish flu didn't originate in Spain. It originated here in the US. The Spanish, when they were infected, they called it the Spanish flu and the word stuck. Like when people say, oh, it's the China flu. No, it's not the China flu. We don't name things based on a country. We name the things based on a organism. That's why they changed it from, SARS-CoV-2 to COVID based on the organism. Okay. Then from the 1980s to till today, we're still facing HIV. It's still spreading. 2003 SARS, then 2009 to 2012 H1N1 influenza. We shut down schools in Collin County where I live during the H1N1 influenza. Then there was MERS, the Middle Eastern respiratory syndrome. Then we had Zika in Texas and the US. We had Ebola in Dallas. A person came from a hot spot, got admitted in Presbyterian, and he was diagnosed with Ebola, infected a few people. We were called the hot zone, Dallas was. Flights were kind of restricted for us. Okay. Then measles. Yeah, you want to go to Disneyland? There was a measles outbreak out there. Okay. And as of this year, it's COVID. Yeah. So this is how I study each disease. This is called a mind map. I looked at H1N1 influenza in 2003. I looked at the disease process, the types of symptoms, signs and symptoms. How do you define a case? How do you define an exposure? Okay. Then I look into the epidemiology. of which area is being affected. I looked at individual cases, public health measures of containing this disease of H1N1 influenza. What do we do in dental schools? What do we do in a dental practice? What are the tests there which we need to undergo to see if we are negative or positive? Are there any vaccines that have come into the picture? Then what are the types of treatments that can help control, mitigate these conditions? So this is how I study a disease. Okay? Same thing I did with SARS. Then the same thing I did with Ebola, because I live in a hotspot, right? Now for COVID, it was a little more complicated because we are still in the epidemic and things are changing. Okay. So let's talk a little bit about, this virus is present in animals such as camels, cattle, cats, bats, humans, the SARS viruses. So COVID is one of the types of coronaviruses. Okay. We've seen it jumping from being it being a zoonotic disease, and we've also transferred it back to cats to an animal. Some of the feral cats in New York City were tested positive. Okay, and it could have been because of the human contact with them. So it goes both ways. Okay, so as of today, there are about 12 million cases in the United States. Okay, and there are close to 250,000 deaths. Yeah, on social media, people say, oh, there are more deaths due to this, there are more deaths due to that. Well, there are treatments for this and that, but not yet for coronavirus. Let's hope by next year, by summer next year, we'll have vaccines available for the commoner, you and me, a common citizen. Okay. Till then, we don't know. We don't know whether the vaccine, how long the vaccine's anamnestic response is going to be. Is it going to be an annual thing, like the flu shots we get? Or is it a one-time thing like um, polio or measles, mumps and rubella? We don't know. We still have to study the population. Okay. So there are close to 15 different signs and symptoms of COVID. Okay. That you can find it on the CDC's website. They keep updating it. Okay. What are the control measures we have to follow? Okay. We have to communicate with the patients. We have to communicate with our own dental team based on the local risks and the local guidelines. Okay. We have to practice control measures such as universal precautions and standard precautions because that is always there. In addition to that, we have to also practice additional precautions or transmission-based precautions. We have to think about what we can do as work practice controls versus engineering controls. And here, engineering controls play a very big deal. Okay. Then we have to think about testing, immunization, and so on, or vaccinations. Okay. So let's talk a little bit about symptoms. The spread can be through asymptomatic people. Before the people show symptoms, they are shedding a huge load of viral particles. Okay. So before I show 100.4 degrees Fahrenheit in my body temperature, the day before that, I'll be shedding the most amount of viruses. That means I'm highly infectious. Okay. So those people will slip through your clinic. Fever, cough, shortness of breath, non-respiratory symptoms for 2 to 14 days. Every so often, almost every other day, I get a ping on my voicemail or my email or my social media account. Hey, doc, we were just exposed to a patient who had COVID. We had one of our staff members who turned positive for COVID. What do we do? I mean, it's 9 months since COVID happened. By now, you should have had it pat. They're still asking me, should we wait for 5 days? Should we wait for 14 days? No, read the material. 14 days is the maximum. Talk to your county health department and your doctor. They will get the tests done. They will make sure if you're positive, you stay home, quarantine yourself, from your family, as well as others, for a given number of days, 14 days or whatever, depending on when you're exposed. So they will also do a post test to see if you are okay to get back into the community sometimes. Then there are situations where if you work in a hospital setting, you are tested quite often, repeatedly. If you are suffering or a high risk group and you want to go for a medical procedure or even a consult, they will ask you to get tested and come. Why? Because that's the first way of controlling it. If you know who you are, if you know that you have the virus in you, you are at risk of transmitting it in your neighborhood. Okay. So, things to consider: contact with other known infected people. If you know that this person was infected and you're exposed to them for a duration of 15 minutes or more cumulative over a period of a day, you better watch out and go get tested. Okay. Travel to high risk areas during initial outbreaks. Thanksgiving is coming. A lot of people are staying back home because they're afraid to go, and rightfully so. We don't know. Then we talked about droplets at the beginning of this pandemic. Yeah, 6 feet distance. You know, inside a building, a 6 feet distance is nothing. I will talk about that when we talk about droplets and aerosolized particles. Droplets can possibly settle down, within 6 feet. But if you sneeze or cough, those can be carried up to 18 or 20 feet. Plus, you have airborne particles, which kind of bioaerosols. They say suspended in the air for up to over a day sometimes, if there's not enough of air evacuation. Absence of a proven vaccine or curative measures as of today, because they still haven't been released. They're waiting for, an emergency release from the FDA. Then idiosyncrasies within the dental practice, close contact of patients and team for prolonged period of time. You're talking of 30 minutes, 40 minutes for a procedure. You're exposed to the patient for that long. Okay? We generate droplets, aerosols. We got to consider general dental care versus hygiene and surgery. Okay? Inadequate PPE. We could buy a box of gloves for less than $5, nitrile gloves, before the pandemic. And today it's going at about $35 a box. Come on. Okay. Why? Because common people are buying it and it's being sourced to hospitals. And people are not manufacturing more. So there is a shortage of supplies. Let's not even go into N95 masks. That has become a real hotbed of controversy. People have been using it for a week in some clinics, and they've been putting it into different types of reprocessing units, which are not even approved or even tested. On some of these media, I put out the standardized, or the best practices for reprocessing these from AMI. That is the Association for the Advancement of Medical Instrumentation. They got the best of the scientists and did certain tests, high quality tests. That thing had only 2 clicks. Whereas when I said a Chinese box that will decontaminate your mask within 30 seconds, oh boy, I had about 60 likes. See, people don't want to read or understand what is good. The minute you reprocess it in an inappropriate way, your N95 mask will get to be useless. Okay. Then, during a high epidemic time in a local area, you again fall back, into the urgent and emergent care, and they will restrict any procedures that can aerosolize the saliva, or the aerosols bouncing off the surfaces of the mouth into the air. So, risks of morbidity and mortality. Age. The older you get, your immune response is weaker. So you're at a higher risk. Sometimes up to 30% higher risk than a normal walking, talking citizen on the street. Gender. Males have a higher risk than females epidemiologically. Then the habits such as smoking. Okay, this has been proven even for um, other lung conditions, like Legionella pneumophila. Okay, underlying medical conditions like hypertension, chronic respiratory conditions, post chemo and radiotherapy, immunocompromising conditions. It could even be micronutrient deficiencies, a chronic one, or even Crohn's disease, where your absorption of food is minimized and your nutrients are not absorbed. You are immunocompromised, period. Okay? Uncontrolled diabetes. The higher your A1C, the higher the risk. So these are some things to think about, and we get all these patients into the clinic. They could be spreading it to you, and you could be spreading it to them. It's a two-way street. So let's talk a little bit about the differentiation between particles that come out of the mouth and the nose. Okay. So they could be airborne droplets, contact, or fomites. Okay. Think about it. When you cough, you're coughing through your throat, right? The tube is larger. So when you cough, the force of expectoration or throwing out particles is much lower than a sneeze. A sneeze, the velocity is much higher. You're talking, when you sneeze, you're sneezing through the nose as well as the mouth at a very high velocity. Both a cough and a sneeze develop both size particles above 5 microns and below 5 microns. The ones that are 5 microns and that are laden with humidity will tend to settle down due to gravity. Okay, so if your cough is strong enough, it can travel up to 6 feet and it can fall down. If it's even more strong, it can travel a few more feet. If you sneeze, you'll still have both the particles, the bigger ones and the smaller ones, that will travel. The bigger ones will travel further. The smaller ones will get aerosolized. That means they stay suspended in the air. The ones which are less than 5 microns in diameter. Okay. So think about that. Progression of the disease. I mean, we all know fever. I mean, we are asymptomatic to fever, to cough, myalgia, dyspnea, respiratory distress, huge amount of sputum production. Okay. What is the impact on dentistry? Absenteeism in the dental team. A lot of people dropped out of the dental team. Okay. Change in the pattern of commerce in dentistry. Common people using medically necessary devices like masks, respirators, gloves, and antiseptics. Those are not available on your grocery stores shelves. Cancellations by patients because they're either afraid or they don't want to do anything right now, or they don't have money because they've been laid off. So those things impact dentistry, the earning in dentistry too, the commerce in dentistry. We cannot manage off-peak hour service, no drive-through service for care. In dentistry, the only thing you can do through teledentistry is possibly radiology. You can't do an exam. It's not like going to a dermatologist or doing a consult with a dermatologist or a physician. We open the mouth, we probe, we palpate, we look inside the mouth. Okay. Interrupted supply. Classification of needs require physical contact with the patient. Okay. In dentistry, until and unless every patient has an intraoral video cam, tip, then you might be able to break into a certain level of teledentistry. Okay. So here you see we fall under the highest risk of being exposed to bioaerosols, droplets, and air from a patient's mouth because we practice within 1 foot distance of the oral cavity for 30 to 40 minutes per patient. Okay? So let's not worry about lack of the restrictions because of uh, lack of supplies. Supplies are now available, yet they're expensive, so we are being frugal. Okay. But one good thing I know about dentistry in the United States is they are much, much better educated. Although I have my gripes about it, I still feel that I would go to any dental office in the US and get a better level of care than most parts of the world. And I've traveled around the world 40 times. Okay. So what you're doing, whether you're doing it as, monkey see, monkey do, copycat, you're still doing a better job than many other places. The only thing is I request you guys to learn the concepts, understand the whole subject. Okay. So what are the steps to reduce the risk of exposure to COVID in a dental office? Have a plan. The ADA has got a very nice screening, plan as to what you need to do within the clinic. Apart from that, you got to communicate with your patients well in advance. Okay. If you're not feeling well, please call us and cancel it. Even the morning of the appointment, if you're not feeling well, don't come, cancel it. Now, if you come, we want you to fill out your questionnaire online. That'll be much better than getting them to sit in the office and fill out the questionnaire, and then take the temperature. Instead, there is a software, Sign In Online is a software which was developed by a teenager in North Texas, and it's being used worldwide right now. They sign in, they answer all the questions. All they have to do is when they enter the clinic, they get the temperature taken. The temperature is okay, boom, you get shuttled into a chair and you start the treatment. If any of them are negative, you're asked to go home. Okay. Screen your own staff every day. Take your body temperature. Fill out the form to see if you're at risk of already acquired COVID. Do it twice a day. I've had clinics. Morning, one of the employees was fine. In the afternoon, the employee had more than 100.4 temperature, is not feeling well. The whole clinic had to shut down for 8 days. You see? Non-occupational risk at home and community. Okay. Think about when you go out into the grocery store. When I drive by a grocery store, I look at the number of cars out there. There are 300 cars by 7 o'clock in the morning. All I want to do is go pick up my milk. That's an issue. Do the people out there practice, physical distancing and infection control or better hygiene? Not really. Okay. Try to avoid crowds. Try to avoid big games and all those kinds of things. It's okay. 2020 is a bad year. Let's go past it. 2021 would be better. If you have people who are dependent on you at home, who are high risk, you got to be really careful, both in the clinic, in the community, as well as at home. Okay. So follow the guidelines, and it's always good. Practice good not oral hygiene. Practice good hygiene measures, infection control and occupational safety. Revisit your standards. Restrict the number of patients. Even today, I tell people, let one patient in at a time per chair, not more than 2 or 3, in the clinic at a given time, even though you're at a low risk population wise. Provide them a mask if they have to wait. Okay. Sneeze or cough screens at the entrance, where you check in your patient. If you're a faculty or somebody else or normal person, telecommute if you can. Okay? Hand washing with approved antimicrobial soaps. I would go with at least a 2% chlorhexidine, 0.2% chlorhexidine gluconate hand soap. You know, stay away from all the other, different kinds of things, benzalkonium, fluoride, chloride, and all those kinds of soaps. Stay at home if sick and health risks, or if you have high health risk factors. Distancing is important. Not using others' devices and spaces. Good housekeeping and decontamination with intermediate level disinfectant. You ramp up your disinfection protocol before the patient, after the patient, clinical surfaces, common surfaces. All of them have to be wiped down between patients. Develop policies and procedures to refer sick people, to reduce exposure. You can send them to a county health department if somebody answers, "Oh yeah, I have cough and I have a little bit of fever." Don't hesitate in telling them that go to the county health department or your doctor immediately, or call your doctor and follow up and get tested. There's nothing wrong in that. You cannot refuse treatment, but you can always defer it to a date when they are, relieved from their, infection or disease. Employee self-monitoring if suspected or of exposure, or if they get sick. Tell patients to call back. Okay, now you treated a patient. The patient's left. Patient's gone home. 3 days later, the patient falls sick with COVID. You got to ask them to call you back. So before the patient leaves your clinic, tell them, if you fall sick within the next 1 week at least, call us back and let us know when you fell sick, so that you can actually retrospectively gauge when and where, who all were exposed, and then go for testing or quarantining or shutting down the clinic. Okay? Use air evacuation devices with HEPA filters, and better if it also has a ultraviolet chamber, a high intensity ultraviolet chamber at 262, 263 nanometers wavelength. That tends to denature the viruses as well. Get good ones. Just don't buy something from some other country which is not even, of a medical grade. Most of the medical grade ones cost at least about $300 without the UV light, but they use a medical grade HEPA filter. Keep them running through the clinic time. Have multiple of those. Have one in the waiting area. Have one in each operatory which you're going to be using. Have one in your lunchroom. Yeah, because everybody takes off the mask and goes and has lunch, right, together. Have one in the lab if you're going to have more than one person in the lab. So those are some of the things you got to think about. Okay? Develop, implement, and communicate about practice flexibilities and protection. When they restrict you only for emergencies, you got to let the patients know why you're canceling their appointments. Advertise on your own web page about what you're doing in your clinic. How many patients can you see? If there are any restrictions, and so on. Follow the guidelines. This is a good time to actually revamp your training in infection control, especially the transmission-based precautions with respect to COVID. Okay? Then think about health benefits for your employees, or the financial stuff as well, because that is one of the big things which impacts the practice of dentistry, finance. Okay? Think about those things. It's very important. I don't deal with that aspect. HR, lawyers, they can actually deal with that. Workplace controls, high efficiency air filters, HEPA filters. Okay, increase ventilation rates, from 2 or 3 to about 10 or 12 if you can. Physical barriers, negative air pressure rooms in hospital systems. Appropriate procedure-based HVE and rubber dam. Whenever you're going to be generating bioaerosols, if possible, use a rubber dam and always use a point of evacuation, high volume evacuation system, four-handed dentistry. Okay? Hand instruments versus air water syringe and high speed instruments to reduce bioaerosols. All those things you got to again fall back into old school days of dentistry. So we've talked about all these things. Follow OSHA standards, the CDC's recommendations. Yeah, communication. Here it lists out what you need to do to communicate with the patients and your staff. Okay. Work practice controls, strict personal hygiene and cough etiquette, more hand washing. People have forgotten to wash their hands because they use gloves. Actually, you should wash your hands twice as much if you use gloves. After washing your hand, then use your, alcohol or antiseptic hand wipes or gel. If you don't wash your hands and use, an alcohol gel, it sticks all the dirt onto your skin. It doesn't remove it. Face masks to control droplets. You can use a level 1 to level 3 to N95 depending on what you're doing. Face shields with a mask, disposable PPE and gowns, strict aseptic techniques and unit dosing. Unit dosing is a concept where, based on the procedure, you dose all the materials, and once you finish treating the patient, if there's anything left over, you discard them. Okay? Don't take it back and try to disinfect it and do all those things. Discard them. Okay? Diligent surface disinfection. You got to disinfect the surface with a strong, approved, intermediate level disinfectant. We'll talk a little bit about that. Hand instruments for prophy, if it's possible. Reduce patient visit time. Don't swap spit and talk stories with the patient. Patient is there for treatment. Be professional, be courteous. Tell them, let's get you out as soon as possible from here and treat them. Launder your scrubs daily. Once you go home, before you go home, wash your hands, wash your face, get into your car, wipe your controls and all the good stuff. Once you go home, take your clothes off, put it into the washer dryer, have a shower, and then get in with your family. Okay. In the waiting room, keep an alcohol, gel or alcohol wipes, and a mask if a patient needs one. Okay, it's always a good thing to do that. So there are different levels of protection against respiratory conditions. Level 1 is standard precautions like hand hygiene. Level 2 is contact precautions, use of gown, gloves, contact with the patient or the environment. Number 3 is eye protection for all patient contact. Number 4 is respirator, that is at least N95 rated. That means it filters out 95% of particles that are about 0.3 microns. Okay, but these respirators have to have a face fit. Not all employees can have a good face fit. I know people who have failed a face fit. Okay, it has to be fitted and the size and the type. So what is a respirator? It's a PPE worn on the face, covering nose and mouth to the risk of inhaling hazardous airborne particles. Okay? So for us in dentistry, when we are treating an active or a high-risk patient or doing high-risk procedures, it's a good idea to use an N95 plus, like in the sense N95 and above. Okay? So here is a P95 or N95, but this is not permitted as yet because this doesn't have a valve. When we blow out, there is no valve. There is an open valve which lets the air out. But when you breathe in, it protects you. It doesn't protect people around. Okay. But as of last week, I heard that NIOSH is coming up with a fix for that, where breathing in and breathing out using an N95 or a N100 mask will still be good. Okay. They'll be adding that extra filter layer for when you breathe out. Okay. So this is a frontal view of an N100. It's got two little disposable filters. The face fit is amazing. It's like like car door. It's got the silicone beading. Once you shut the door, you can't hear anything outside. Same way, it just doesn't need a real face fit. Somebody to come and fit you. You can choose an approximate size for your face, and it sits like a seal around your face. Okay. On top of which, you can wear a face. You must wear a face shield. Okay. Some of these face shields come with a slot also for loops. Okay, I don't like those things because they're pretty flimsy. So the classification of respirators, I'm talking of N95 plus. They're particle respirators which filter out airborne particles. The other one is a gas mask which filters out chemicals and gases. The third one is an airline respirator which uses its own compressed air from a remote source. They're centralized, like in labs and stuff like that. The fourth one is a PAPR, positive air pressure respirator. It's self-contained breathing apparatus, which includes their own air supply and it's battery operated. Okay. So here is a PAPR. This is it actually filters in air with a very high HEPA filtration rate, creates a positive air pressure so that it is positive and it doesn't fog up inside. And when you breathe out, it breathes out again. It sucks out air from another source, other outlet. Okay. This is the best, but they cost a few $1,000 a pop. The next best would be one if it is approved with a blowout filter as well. That is the N100s. The least among the respirators are the N95s, as you see here, which needs a face fit. Okay. So the N stands for not resistant to oil, R stands for somewhat resistant to oil, P is oil proof. Okay. So look at the face fit. P100 versus an N95. N95 has a very flimsy, thin area around, which can fit your face, whereas this one will seal it up. That's the difference I'm showing. Now, the different types of germicides, the disinfectants you need to use in your clinic. I am a proponent of a higher quality, very effective, intermediate level disinfectants. Okay. I look at halogens, as a starting point. The next level is I go into hydrogen peroxide. So your choice of an intermediate level disinfectant should have a TB kill claim. It should have an EPA number. It should also be cleared as a hospital disinfectant where it is effective against Pseudomonas aeruginosa, Salmonella typhimurium, Staphylococcus aureus. These are the marker organisms for hospital infections. They must also kill hydrophilic and lipophilic viruses, and they must kill fungi. So I like the best one you have today in the market is a hypochlorous acid. One is made by Dolphin Pods, called Dolphin Pods, and then there's another one called Everclean. They're called Pure Tabs. Both of them are 3,000 parts per million or more, and they're very effective in a very short time, and they're very powerful. And they are not corrosive like a bleach. Its pH is around 6, so close enough to water. The next level I would look at is hydrogen peroxide or accelerated hydrogen peroxide. That's also very efficacious. I'd stick with these. I would stay away from quaternary ammonia compounds like Avicide or Vexide, this side, that side. all those things. I mean, they are the weakest of the disinfectants, but they always get their claims. Okay, call me old-fashioned, but I am good in that. So engineering controls. We talked about, there are two different types. Ones which come with, these are air evacuation and filtration systems, which are portable, which you can place in each of the areas in your office. This one is made by Surgically Clean Air. They have a HEPA filter, as well as they have a UV light, and they're fairly expensive. Okay, they're very efficacious though. Okay, the next one is centralized systems. If you have a large building, it becomes much better to go into a hospital grade air filtration and air evacuation system, which actually filters out, it neutralizes the particles and sends back cleaner air. Okay, it's constantly running. Okay. The next level is also, I mean, there's among the uh, portable air filtration, there's a Medify system, then there's IQ Air, and there's also one which is made by Honeywell, which is about $300. All of these are pretty good. Okay, when I go into any of the clinics I've trained, I'm so happy to see people use these things. Okay, none of those clinics that have used any of these have had a single case originating from the clinic. Okay. So let's talk a little bit about what are your risks. If you're treating a known patient, your risks are very, very high. Treating a non-infected emergency is high. Triaging with full PPE, including your N95s and all the good stuff, is medium. The clinic being shut down is low risk because you still have the community you can pick it up from. But I would not advise for shutting down your clinic until and unless it's the last thing. Let's talk about COVID testing. There are a lot of tests which are available. There are short-term and long-term tests. There are, PCR-based tests which give you results within 15, 20 minutes, and then there are antibody tests and so on. All these tests, I mean, manufacturers make claims, but when academics test it out, as how effective it is in the population. If somebody says I'm 90%, I mean, my test is 95% accurate or sensitive, when you translate it into a population, it could be about 50% accurate. Okay, we're still in the process of improving the tests. An antibody test should not be used for diagnosis. Okay, the next thing we talk about is vaccines. As of today, 3 companies have come out with something in the US at least with good numbers on their internal testing, but their sample sizes are much smaller than what translates into a population. So if they say 95% accurate, I would take it with a pinch of salt and say, well, it might be 70% accurate, okay, in a population. Now, do we need to take this annually, or is its anamnestic response is as good as a polio vaccine, which will last for years, or a hepatitis B vaccine, which will last for years? Do we take one, or we take one and then a booster dose repeatedly to develop our titers? All these things will play into the equation. By the way, when I look at CIDRAP, Center for Infectious Diseases Research and Policy, and some of the other educational institutions of high caliber, like Johns Hopkins, Emory University, Baylor Health Systems, most of the consensus from these experts who spent their lifetimes is that by the time it trickles down to a dental office or a healthy dental health worker, it'll probably be June, July of next year. So till then, please stay and practice safely. Thank you. Hello? I'm open for any questions you have. Hello, moderators. I within the content of the presentation itself, I've answered quite a few questions which I've had for the past few months. Because I mean, I go back and forth modifying my slides. But is there any specific experiences or questions people have would be helpful to me as well, so that for the next presentation I can actually add those things in. If there are no questions so far, I'll give a 5-minute break and then I'll load up the next presentation. Okay. Hold on just a second. Let me go out of this. So, can you see these slides yet? Yeah, I'm trying to see where the share is. Hold on. Okay, now where am I? Okay. Okay, there we go. Can you see this now? Yeah. Now let's take a couple of minutes break so that I can refresh my coffee, and I'll be back in a minute. And just pour myself a cup of coffee, and I'll be back. Yes, hello. Sure. Hi, everybody. This chapter or this topic is instrument reprocessing and sterilization monitoring. Most of you know most of it, but there are some little tags that people overlook, and we'll go over these. Okay. So again, I am from Tutsi. Now, these are the disclosures I do whenever I'm lecturing to a large group. I have not received any funding to make this presentation from any company. I've been a consultant for over 30 dental industries, including the federal government in the US, EU, Japan, you know, and so on. All of these have been vetted by the university. I worked as a professor in the university, so there's no pay to play kind of a thing out here. Everything is above board, and this is all for consultancy in research and development, and everything has gone through the university. Oh, hold on a second. Oops, slideshow. I have to hold on a second, please. Okay. Okay. Before we go into sterilization of an instrument, we have to understand three concepts: sanitization, disinfection, and sterilization. Okay? Any instrument that needs to go into an autoclave has to be cleaned first. It's called a step in sanitization. It's a process of physically cleaning to reduce the quantity of microbes and the bioburden, including all the tissue tags and so on. Okay? Here we use, we could use an ultrasonic solution to sonicate the instruments, or we can use soap and water and a brush to clean those instruments, and then we dab it with a paper towel. Okay? Rinse it and dab it with a paper towel. Ultrasonic methods are much better than physical methods of cleaning. It's a few thousand times much more efficacious in removing dirt. All critical and semi-critical items and non-critical items, should be microbe-free or at least clean before they go into an autoclave. Okay? But not environmental surfaces, I mean. Okay? Disinfection. The next level of cleaning and controlling contamination is disinfection. It is one step above sanitization. It is a process to kill all vegetative organisms, but not necessarily bacterial endospores. Okay? So there are different ways we can disinfect. We can use a germicide or a liquid disinfectant. We can use X-rays. We can use ultraviolet rays. Now, for disinfection of impressions, counter surfaces, and equipment between patient, we normally use a surface disinfectant liquid. We do not disinfect instruments used in intraorally. They have to be sterilized. Okay? So you can also disinfect non-critical items and environmental surfaces, but with a low-level disinfectant. Okay? Sterilization is the highest level of controlling microorganisms in causing infection or disease. Okay? It's a process to kill all bacterial and viral contaminants, including bacterial endospores and fungi. Okay? These could be chemical sterilants such as chemiclaves, ethylene oxide, gas plasma, liquid sterilants for immersion, or there could be physical methods like autoclaves, dry heat, rapid heat transfer, and gamma irradiation. All critical and semi-critical items must be sterilized because both of those items end up in the oral cavity. So let's talk about adaptation of Spaulding's classification to clinical surfaces. What is critical? What is semi-critical? What is non-critical? What is environmental? Critical and semi-critical surfaces tend to enter the oral cavity. They pass the vermilion border. The ideal way to reprocess them is through sterilization, or they should be single-use disposable items, or they should be clean supplies if they are not intentionally used for, you know, uh, any percutaneous applications. Non-critical items can undergo surface disinfection, like wipe it down with a surface disinfectant. These are items that do not enter the oral cavity. They are the items that surround your workspace, your bench, your controls, your bracket table, and all this good stuff. Then you have environmental surfaces like floors and walls and stuff like that, which basically is a part of your clinic, but you hardly, get those items which are lying on the floor or on a wall into a patient's mouth. Okay? So here, let's talk a little bit about critical items. Critical items are those that are used to pierce or puncture or cut or you know a tooth or soft tissue inside the oral cavity. Could be, you know, instruments used in oral hygiene, prophy, diagnostic instruments, needles, and so on. All these items must be sterile. Okay, so they should be either single-use sterile disposable devices or reusable devices. I put this one also in the anesthetic carpule as well in it. The reason why I do this is when I lecture in certain parts of the world, I still find people using one carpule on two patients. Not a good idea. Okay. Semi-critical items are non-sharp items such as a handpiece, a mirror, amalgam carrier, amalgam condenser. Those all can be autoclaved. For surgical purposes, you have evacuation tips, which can be autoclaved, or they could come sterile. Now, when you're not doing any endosseous bony procedures, you can use clean supplies, such as a saliva ejector tip and a high volume evacuator tip. Okay? The third level is non-critical items, those that do not enter the oral cavity, such as your bracket table, your chair controls, and your hoses, and so on. All you need to do is spray, wipe, spray, spray and wipe. That is the sanitization part. Spray and leave the disinfectant on the surface for the given TB kill time. And that is disinfection of the surfaces. Okay? The last one is environmental surfaces. Common housekeeping methods of keeping it clean. Kitchen clean is good. Okay? Basic rules in reprocessing. Always clean instruments before sterilization. Sterilization is a must for critical and semi-critical items. Only disinfect if equipment cannot be sterilized. Heat or heat plus chemical methods are superior to chemical immersion methods. Weekly sterilization monitoring in the US is a rule for every single sterilizer in use. Test ultrasonic machine monthly, okay, using a foil test. Take good care of your equipment, proactively. So let's see. Here we've treated a patient. We separate instruments from the waste on the bracket table. We get rid of the sharps and regulated waste into their respective sharps container or the regulated soft waste bag. We immerse all the instruments other than the handpiece in a holding solution to keep the bioburden moist. Okay. We take it out and we sonicate the instruments, depending on whether it's kind of in a cassette or loose instruments. For cassettes, it's about 15 minutes. For loose instruments, it's about 8 to 10 minutes. Okay. We rinse the instruments and we dump all the instruments on a white Turkish towel. And there we inspect the instruments to see if any of them are still contaminated visibly or have tissue tags hanging around. What I found in some of the scalers, I find after sterilized, when I open up a cassette, I find a previous patient's tissue tag all baked onto the scaler. That's horrible. That's why you need to inspect your instruments. Those instruments which have not been cleaned through sonication, you pick them out individually with a long handled brush, you clean those things and then dry them and put them back in the set. You bag them and you sterilize them. So what do you need? What is the PPE you need while doing instrument reprocessing and getting rid of this waste? You need to use nitrile utility gloves, the Smurf gloves, I call them. Okay, they are cut and puncture resistant as opposed to a regular exam glove. You need protective eyewear, a mask, at least a level 1 mask, gown so that your clothes don't get dirtied. Okay, that's the basic stuff. If you want to use a holding solution or a tub with a holding solution, you dilute the ultrasonic solution times 2. Now, if you're going to use an ultrasonic solution, you dilute, normally they'll tell you X amount of ounces per 1 gallon of water, blah, blah. You dilute it times 2. That means you add more water. It keeps it moist, keeps the bioburden wet, so that when you transfer it to your instrument into your ultrasonic machine, those tissues come off the instruments very easily. Okay, don't keep it in the holding solution overnight. It tends to pit out the instruments or corrode the instruments. It shouldn't be there for more than 15 minutes. Okay, let's talk a little bit about ultrasonic cleaning. Ultrasonic cleaner acts through a process called cavitation, or it has implosive activity. It's opposite of explosion. When it implodes, it creates an air pocket and pulls everything towards that pocket. Okay, it tears off all the dirt from the instrument surface, pulls it away from the instruments. These implosive forces detach bioburden. The instrument need to be suspended. Don't pack the instruments on one over the other without enough of fluid between them. Okay, you can use enzymatic solutions, ionic or non-ionic solutions. I prefer enzymatics and non-ionic solutions because they're the least corrosive. Okay, if and when you still find tissue tags after ultrasonic cleaning of your instruments and inspection of your instruments, you take those out and then you clean that with a long handled brush. Don't use small brushes like this because you can actually cut yourself. Never use exam gloves. Okay, you have to test the ultrasonic cleaner on a monthly basis. Okay, so here are examples. I've done at least about 200 different studies on different devices. Here is an example where I used about 400 burrs and I tested a good sample for each type of classified solutions. Okay, in one, when I used a non-ionic versus another lesser known ultrasonic solution, after 200 cycles, I still find this burr. I use this as a guppy fish, an experimental thing. The corrosion was very minimal, whereas on the other one, look at the corrosion. Okay, this is dangerous. The tip will break and a person can aspirate it, So be very careful in what you use. So this is a study we presented at the International Association for Dental Research way back in time on the things. Here's the insides of an ultrasonic bath. There is a basket, there's a bath, and there's a basket within the bath. It's got good handles. Never put your hand into an ultrasonic machine that is running, or never use any calipers or a forceps when it's running. Shut it off and then try to reach out for an instrument. If you want to remove all the instruments, you lift this whole basket out and then put it into a sink, rinse out all the dirt, okay, and then dump it onto your white Turkish towel or something. Examine the instruments. At the end of the day, drain out every day. Drain out your ultrasonic bath. Wipe it down. It should look this clean at the end of the day. Okay. In the morning, Go ahead and fill up the water in the ultrasonic bath, and then you add the ultrasonic solution. Okay, don't add the solution first and then the water. It'll create a lot of bubbles. Add the water first, then the ultrasonic solution, and then you have to degas it for 20 minutes. Okay. What is degassing? Degassing is when you run the ultrasonic machine for about 20 minutes in an empty cycle, it gets rid of almost all the micro air bubbles which hinder your ultrasonic process. After the degassing, then you can add your instruments in. Once a month, take a aluminum foil, about whatever the size based on your size of your ultrasonic bath. Start the machine, dip it diagonally, up to this level, about half of it, all the way to the bottom. Let it run for about 15 to 20 seconds, and then take it out. You'll see pitting where it was dipped in, and if the pitting is uniform, that means your ultrasonic bath is working perfectly. If you find empty spots, like here, in the immersed area, then you need to actually calibrate your transducers. You have to call a technician, ask him to come and calibrate the device so it actually functions as it's supposed to function. Do that once a month at least. Okay. Then you have other kinds of instrument washers. Domestic instrument washers like domestic dishwashers like Whirlpool and all these Samsung and all those things. They are not meant to be used in the medical field. They're meant for your kitchen, period. Okay. There are devices like this one. This is Mealy. These two are Mealy. High-end devices. They have a 2-cycle, acid and a base cycle, and they have a thermal disinfection cycle. Then you have a smaller one called Hydrim, which is made by Sycan. And all these are good too, but they're kind of expensive. So if you have a larger clinic and you're doing really well, go for these. It's really good. Now let's talk about sterilization. We talked about cleaning the instruments and getting all them ready. We can either put them in bags or in cassettes or as loose instruments, but within a pouch. Okay, sets of instruments within a pouch. So you have something called dry heat sterilizer and a rapid heat transfer sterilizer, which are both dry heat. Rapid heat transfer has a smaller chamber. Okay, it can take very minimal instruments, but the cycle is very fast, as opposed to the dry heat's 2-hour cycle or a 1-hour cycle. Then you have the autoclave or steam sterilization. Then you have the chemiclave, where it uses heat and pressure and a liquid called vaposterol. Okay. So dry heat, the slow cycle is at 160 degrees Celsius. At 170, the fast one is at 170 degrees Celsius. Okay. The rapid heat transfer is 190 degrees Celsius. All these dry heat sterilizers cannot be used for sterilizing your handpieces because they'll break down all the parts in your handpiece. Okay. For the slow cycle, it's 2 hours. For the fast cycle, it's 60 minutes. For the rapid heat transfer, or the Cox or Boma sterilizer, it is 6 to 12 minutes. Okay. It's 6 minutes for unpackaged instruments, 12 minutes for packaged. Now, packaging materials must not insulate the materials, must not be destroyed by temperature. So there are paper bags, muslin, there are different types of paper which is used for this thing. Okay. Unacceptable materials are plastic bags because they'll tend to break down. Advantages, it's effective and safe for mirrors and metal instruments. No dulling of cutting edges or the high carbon steel edges. No rust or corrosion. Rapid heat transfer has a fast sterilization time. Disadvantages for most of the dry heat sterilizers, which most orthodontists tend to use or want to buy, it's a longer cycle time for sterilization, poor penetration, discolor or char fabric, destroy heat labile instruments, and the rapid heat transfer, which is the fastest, has got a very small chamber. It's almost got the same size of a small Sycan unit. Steam under pressure. That's autoclaving. The slow cycle is at 121 degrees. The pressure is 15 psi or 1 bar. The time is 30 minutes. Okay. For the fast cycle, it's 134 degrees Celsius. Pressure is 2 bar or 30 psi, pounds per square inch. The time, the sterilization time is 3 to 5 minutes. So when I talk about sterilization time, it doesn't mean the complete cycle time from cold to cold. It is when the pressure of 15 psi or 30 psi, depending on the slow or fast cycle, is reached, and the temperature hits 121 degrees or 134 degrees. And given the slow or fast cycle time of 3 to 5 minutes or 30 minutes, is the exposure time of the instruments to that heat under that pressure. After that, there's a cool down time as well. Okay, so you have the warm up time, you have the sterilization time, and then you have the drying and cool down time. Okay. Advantages: short cycle time, good penetration, wide range of materials. Disadvantages are if your heating cycle or the drying cycle is not good, it can corrode high carbon steel instruments. Dulling of edges. Packaging may not be completely dry. It destroys heat sensitive materials, of course. Okay. So there are different types of sterilizers that are being marketed or used. Well, I prefer the old gravity displacement method of sterilization of the air or the steam. Okay. What happens is when you put your instruments in and you hit start, it releases X amount of water that gets converted into steam, and it's maintained for the sterilization time at the given pressure. It shuts off, and then the heat and drying cycle takes over, where it removes all the moisture. Okay. So that's a good one, and I like that because it has very little moving parts. These sterilizers last as long as 10 to 20 years. Some of them are really good. Okay. Then you have the B-class sterilizers where the vacuum is removed before and after. I mean, a vacuum is created before and after. So what happens is when you put your instruments in, you hit the button. In a cyclic manner, it sucks out all the air and creates a vacuum, a negative air pressure. In the meantime, it starts releasing steam into the air, into the vacuum chamber. And it keeps cycling it like that till the optimal temperature and time is reached. And then it maintains it for the sterilization time. And then it starts again evacuating all the steam in a cyclic manner, creating a vacuum, but keeps the heat cycle on. This reduces the moisture. And when the instruments come out, they should be absolutely dry. Okay. These are good. They're great for hollow bore instruments, but we hardly use any hollow bore instruments in dentistry that need to be autoclaved other than a handpiece. But even there, I have still yet to find a case that went through, a standard sterilizer versus a B-class or a vacuum sterilizer, where disease has been caused because of a handpiece. Okay, and these things cost twice or thrice as much, and they have many parts that break down quite often. And I'm talking out of 30 years of experience out here. Unsaturated chemical vapor. It is dependent on heat, water, which is less than 15% of the liquid, and it works on chemical synergism. The vapor sterile or the liquid which is used instead of water out here contains alcohol, formaldehyde, ketone, acetone, and water. Okay. The temperature is 131 degrees Celsius. Pressure is at 20 psi. The time is 30 minutes. It allows vapor to precipitate on the item surface. Vapor must not react with packaging. Okay. No contact of plastics with the side of the sterilizer. Perforated metal trays are ideal. Solid trays and sealed glass jars are bad. Okay. Advantages: it's a short time, just like an autoclave. No rust or corrosion of carbon steel or metals because it has got less than 15% water content. No dulling of cutting edges. It's good for orthodontic and stainless um, orthodontic um, equipment, which we use all the you know and also stainless steel wires. Disadvantages: instruments need to be dry before you put them in. Okay, it destroys heat-sensitive plastics. There's a chemical odor in poorly ventilated areas. You should have a good evacuation system or a scavenging system for this one. I prefer this one, but slowly people are using this technology lesser and lesser. Now, on a weekly basis in the United States, okay, you need to monitor your sterilizer using spores, be it a dry heat sterilizer, a chemiclave, or an autoclave. Okay? For dry heat sterilizers, we use Geobacillus subtilis. For autoclaves and chemiclaves, we use Geobacillus styrothermophilus. Okay? There are different types of spores. The most common reasons for sterilization failure is overloading, improperly packing, okay, breaking a cycle, or not servicing the sterilizer regularly, or not reading the output, whether it says sterilization cycle complete or the cycle was stopped. Sometimes people don't look at it. They just take it out and then try to stick the instruments and start treating patients. So you have two different types of monitoring. You can do a mail-out monitoring of spore strips, or you can do an in-office monitoring using spore ampules. Here's an example of a spore strip. It comes in a glassine envelope. Okay, the spores are impregnated onto this little white strip inside the glassine envelope. You take this envelope, put it in along with an empty cycle or with the instruments once a week, run it through, and you'll have a control which is kept outside. You have to label them as sterilized and then control as well, and send both of them to a remote lab, where they will go ahead and process it. They'll put it into, the trypticase soy broth, and at the different temperatures, they kind of incubate them, depending on whether it's a dry heat or a you know, or an autoclave. And then in about 3 days, they get a diagnostic result. If the cycle was successful and killed all the spores, the broth will remain clear like here. With B subtilis, you'll find a ring out here and slightly murky. B stereothermophilus, it'll always be murky or milky. That means it's a failure. Okay. Then you have in-office spore testing ampules. These, they can give you a result much faster than mailing it out. There are some items which give you a screening test within about 6 hours and a diagnostic test in about 24 hours. But they're quite a kind of expensive. Okay. So this also can be used in lieu of the mail-out spore strips. Okay. Now, apart from that, the sterilization monitoring industry has come up with a whole bunch of rapid surrogate tests. For example, they use a class 5 indicator where there's a wax thing, which once it's kind of sterile, it goes beyond this little blue box. That means you accept it, that it's gone. These are all pegged to the efficacy of the bacterial endospore tests. Okay. So basically what you can do is, for I prefer to use this for high-end instruments, like when you're doing implants. All the accessory stuff which needs to be autoclaved, like your torque wrenches, your burrs, your trephines, and all the good stuff. Along with that, I would definitely put in at least a class 5 indicator with the indicator surface pointing outward, so you can actually see whether it's gone through a complete cycle and successful before you get it out. Sometimes you can also use a spore ampule, okay, and you can incubate it within your office. Okay. I would suggest that. Go ahead and do that. So let's talk about different types of surrogates, like the chemical indicators. Class 1 chemical indicator is basically the zebra type of a tape, that the beige colored tape we get. It's clear. Once you apply heat to it, it turns like a zebra stripes it provides. Class 2 is a Bowie-Dick test. It's meant for use daily, at least once a day, for all B-class devices or the vacuum sterilizers. It actually tests the air evacuation. Okay. Then class 3 is for dry heat. Hardly anybody is using these today. Class 4 is multi-variable. That means it reacts to two or more critical variables, such as humidity and heat. Those are the two parameters which were achieved, such as time and temperature, humidity and temperature, and so on, or humidity and time. They are not all that reliable, in my opinion. Class 5 indicators or integrating indicators, they have that waxy thing which goes from a fail to a pass. Once it says pass, that means it's almost as good as a spore strip, so you can release those instruments. Class 6 are emulating indicators, and those are the ones which actually are specific to a type or a model of an autoclave. Suppose you have a G4 made by Cycan. Their emulators will actually be pegged to the cycle of that particular autoclave model. Okay? And those tend to be expensive too. So here's an example of a class 1 on a tape. Here is an example of the pink turning chocolate, okay, on your pouches. Here is a Bowie-Dick test which you have to run on your vacuum sterilizer every day. These are quite expensive. They cost about $7 or $8 a pop. Then class 3 indicators is for, it's got a wax pellet which tends to melt, for a cycle, and that's used for dry heat sterilizers. Class 5 is, it looks like this before you put it in. After a complete cycle, you see this black line going all the way through. Okay, it's got a waxy item, so it needs steam and pressure for it to move, for it to move from zero to complete. Okay. Then you have different types. This is a fail and this is a pass because it never reached the safe area. Then you have integrating indicators for 3 variables, made by, it's called ProChem. It's meant specifically, so this is a new one which has not been used. Here it's a fail because it never reached this accept mark. Here it's a pass which is an accept mark. You tend to put them into all these indicators whenever you're using. You put them in face up, so that you can see it through the clear side of the pouch. Now, this is what we did in a fairly strong product development and a research project. For about 4 years, I served as a consultant to a semiconductor manufacturer, Maxim Integrated. They developed, initially a chip which was encased in a small, perspex sheet. Okay, this is how it looks: about 2.5 centimeters in height and 2.3 centimeters in diameter. It goes into a cradle. The cradle is attached to an USB through an RS-232, and the USB is attached to your computer, and it's got its own software. Okay. What it does is it actually logs the complete cycle from zero to finish. Okay. It gives you a pass or fail based on the type of cycle you already programmed it for, and also it saves all the information every 10 seconds into a CSV file or an Excel spreadsheet kind of a thing, as well as it saves it as a PDF which you cannot tamper with. Suppose all the parameters are not met, and if it's a failure, this little circle with a check mark will actually be a red one with an X mark. And it also tells you causes of failure, maximum temperature reached, and so on. And it gives you a beautiful graph which tells you how it looked. We went ahead and developed this thing, did a whole bunch of testing on a huge sample multiple times to perfect it. Okay. What we found was it could survive about 400 plus cycles, about 500 cycles without breaking down. That means it could measure 400 cycles. One chip can be used multiple times up to 400, but we kind of restricted it for 150 to be absolutely sure. Now, what we found was when we use the chemical indicator, like the type 1 chemical indicator, before the temperature in the chamber reaches 100, it already shows a pass. Okay. The class 4 and class 5 indicators, they showed a pass less than 1/4 to 1/3 of the cycle. The spores showed a pass less than half the cycle. That means if you had a 30-minute cycle, the spores may show that the cycle was complete and it was a pass when it only covered 15 minutes of this 30-minute cycle. You get it? So basically what we have been using for the past 60 years are items which only measure half the cycle. Okay? They want us on a 121 degrees Celsius temperature to run for 30 minutes. But if it already shows a pass at 15 minutes, why are we doing it? Now look at the digital indicator which we tested. It goes all the way up to 99% of the cycle. That means around the 29th minute of the 30-minute cycle, it may show a pass, but it actually waits till the 30 minutes is over. You can actually program it in such a way that it actually has to go to 31 minutes. If it shows that 31 minutes, you're assured. Okay. So that is the new technologies which are coming up into the market, but I don't know when. Any questions so far? Hello? Is anybody there? Yeah. Oh. Okay. We'll take a 5-minute breather, actually, because it gives me time to kind of wet my mouth again. Yeah. So how many people have logged in so far? Do you know? I just wanted to know. I'm curious. Great. Yeah. Okay. So let me get the next one on, and then save. Hold on a second. Uh-oh. Hello? Hello? Yeah, I lost you. I lost you somewhere. Hold on a second. Yeah, there we go. And share. There it is. There it is. Hold on. Now do you see it? Okay. I'll take a 5-minute break. So it's 4:56 or yeah. So at 5 p.m. we'll start. 5:01 we'll start. Okay. Thanks. Hello, guys. We finished half the training. We got two more items. So this topic will be on HIPAA, or Health Insurance Portability and Accountability Act. Okay. So this deals with information safety of patient information, okay, during the process of provision of care in dentistry and medicine and other fields too. But let's talk about dentistry. So HIPAA is HIPAA, not HIPAA. A lot of people still call it HIPAA. I don't know why. HIPAA is a female hippopotamus. Hippo is a male hippopotamus. I'm just kidding. So, what topics are we going to cover today within HIPAA? The overview of Health Insurance and Portability and Accountability Act of 1996. Within that, the Privacy Rule on Protected Health Information, the Security Rule on Protected Health Information, or PHI, the overview of the HITECH Act of 2008, overview of the Breach Notification Rule, and for those residents of Texas or practicing in Texas, the overview of the Texas House Bill 300 and amendments. This applies only to the practitioners in Texas, the HB 300. Okay. Now, let me go back. Under each of these, you'll find a hyperlink. You click on it, it'll take you there. What is the scope of HIPAA? It protects patients with respect to use and misuse of their personal, health, and financial information. So three things: personal information, health information, financial information. All these three you must protect while giving them care. Okay? Makes it easy when a patient moves from one insurance plan to the other. Like, you can actually port the patient over and their information over as well as. So the last thing is it addresses standardization of format for electronic information, which is used during transfer from one entity to another for either, helping with the move, the information access, and so on, as well as during the claims procedures. Okay? This helps the healthcare organizations, insurance plans, doctors, and patients. So here are some of the resources, okay, on health and human services, okay, where the Office of Civil Rights is a part of that, where you can get all the information for health professionals. You click on the hyperlinks. Okay. What is privacy? Who are covered entities and business associates? How do you determine who they are? Then here's a link to the American Dental Association's site, where they talk a little bit about HIPAA and the different issues they've faced in dentistry. And of course, this last one is HB 300 for Texas, where you click on that, it'll take you to their website to the rule. Okay. So what is a covered entity? A covered entity is a person who directly provides care, okay, is involved within the circle of care. Could be a doctor, dentist, pharmacy, insurance company, and so on. They are totally involved within providing care, within the circle of care. Okay. And then outside the circle of care are business associates, where they kind of help with the process, but they're not directly involved with a lot of the patient information. So how do you determine? So on the HIPAA website or Office of Civil Rights website, there are flow charts which you can actually use, like this one, as to who a provider is. For example, let's go through this. Does a person or a business or an agency furnish, bill, or receive payment for health care in the normal course of business? If it's a yes, does the person, business, or so and so transmit electronically any of the information? If it's a yes, stop. This person, business, or agency is a covered healthcare provider. Suppose they do not, in the normal course of business, do all these functions, then they are not a covered entity. Okay, and they're not a healthcare provider, so you cannot easily share that information with them. Okay? Similarly, who is a clearinghouse? You know, same thing. Which is a health plan, which is a government-funded program. So you have to know all these items before you just jump into handling HIPAA or treating a patient or sharing information or records with anybody. Okay? So in this program, we'll understand how to protect the patient information both digitally and physically using security measures within the clinic and outside. Okay? With restricted access to information and release of specific information for care. Not everything, okay, for direct care. How do you protect electronic information within the clinic and outside? Prevent identity theft. Understand what the FTC, red flag rule exemption, is for dentistry. Okay. Then the next one is you understand the application of patient privacy during provision of care, where you handle patient's information confidentially, like health information, personal information, and financial information. Then you also have to know the patient's right for accessing their health information. The patient has absolute right to access the health information. Determination of whether disclosures of protected health information are acceptable and protected. You got to make the decision. There are guidelines to that. Then you talk about HITECH Act and its impact on covered entities and business associates. It applies security and privacy rules to business associates with the same legal requirements as the covered entities. Okay, to protect health information, detect breaches, and report violations to the Office of Civil Rights. Information, health information it falls under the Office of Civil Rights, so it's a pretty biggie, you know. Then understand the implications of HIPAA and HITECH Act and Texas House Bill 300. Initially, they wanted everybody to convert from physical records to digital records, right? Everybody did that, or most of them did that. Then with the digital stuff came a whole bunch of other problems. How do you protect this digital information where somebody from the back streets of Bangalore in India can hack into your system and download all the information within minutes, as opposed to coming to your clinic and trying to steal all the physical records? You see? The other thing was the HIPAA wanted the records to be clever records, not just dumb PDFs of a scanned thing. It had to be usable with the software. So there came restrictions or requirements for electronic health records with respect to what are the alerts. You know, does the alert pop up? Does it, when you make an entry, does it log that date and time in, and who did that? All these clever things had to be there. When you wanted to share it, would it keep a track on who you shared and how much of what you shared? All these things fall under the electronic health record. It had to be clever. They increased penalties for violations on HIPAA. That's in 2008, the HITECH Act did. Okay. They gave patients legal rights to see, modify their information, and get a copy of the records within a very short time. It also gave them, the patients, the power to easily complain to the Office of Civil Rights if they found that something was amiss. You see? It mandated breach notification. If you got to know that there was a breach in your system, you had to report it. Whether it happened 6 months ago and you only got to know about it today, or whether it happened only yesterday. The other thing is the size of the breach. Was it more than 500 patients or less than 500 patients? What are the things you need to do depending on a large or a small breach? So on. it also prohibited commercial use of protected health information. For example, let's say you are in a hospital system where you have 80,000 patient records available. And if, let's say, Procter & Gamble or Johnson & Johnson or anybody comes and wants to find out how many of their depends, how many of the patients are using depends, you could not sell that information to them, okay? Because it's a breach. It's illegal to do that. Then in Texas, we have Texas House Bill 300, which is a little more stringent than the overall HIPAA. Other than the fines by the Office of Civil Rights and the Health and Human Services, we have additional fines in Texas. Okay? But it applies only to the offices within Texas. So let's talk a little bit about information breaches and costs and fines. So 90% of the healthcare institutions use mobile computing. This was data from Dell, about 10 years ago. One of the really nice studies. I read it from end to end. They use mobile computing. Okay. This becomes a hacker's dream, right? Everything is there up in the air, up in the cloud, up in a rack system, and so on, where they can actually plant viruses or worms that can periodically keep sending all the information back to the black market, where they can sell it in the black market. They found that 61% of the organizations did not know where the data was stored, which place in the world the data was stored. The cost of breaches was about, $6.5 billion at that time. Now it must be about 3 times the cost now. Okay? They found that 96% of the providers had at least one breach, and not many of them had reported it. They found that 81% of clinics used mobile devices. Only 49 had implemented security measures on mobile devices. Now, let's talk about the value of information. Suppose I drive up to a gas station. Before I start loading gas into my tank, I see a credit card fallen down there. If I pick it up and I want to sell it in the black market, I'll get anywhere between $1 to $6. Okay. Personal information. Now, with the credit card, if I have the name of the person, the zip code, or last 4 digits of the social security number, automatically the cost of the credit card becomes $14 to $18 per credit card. But if you have a health record you find, it costs about $50. Why? Because you have the personal information, the health information. You can actually sell it to people who make consumer stuff, and you have the credit card information or the financial information of the patient. They don't need to data mine. They can actually look at the record and say, oops, we can send so-and-so mailing stuff and coupons for them to buy stuff from us. One unencrypted laptop was lost. The cost of lawsuits was $250,000. Letters to clients. This was a laptop with active patient information. Letters to clients was $319,000. Identity and theft monitoring cost over $1 million. And probably the guy who lost the computer lost his job too. Okay? Here are violations and fines by dentists. There was a dentist in Kokomo, Indiana. He was fined $12,000. The next one you can see, at the website of hhs.gov, case examples. Then there's another one where a California dentist had to pay $80,000 in attorney's fees to a patient's parents, okay, to settle a case. Then there was another case in my neck of the woods in Dallas, where a dentist had to pay a $10,000 fine for impermissible disclosure of patient information. Okay. Now, these are actually fines. Apart from that, the cost of handling a case like this will run into tens of thousands of dollars. You have to get an expert to come and protect you and represent you with the Office of Civil Rights and the Health and Human Services. Then you have to do a whole bunch of things. Your name will be all over the neighborhood saying that you had a HIPAA violation. So it really is a big thing. So what is protected health information? Any patient information that can be linked to a specific patient or narrowed down to a patient. Okay, with specific variables which are called identifiers. Identifiers would be, a name. That's great. Age, gender, sex, um, zip code, all those kinds of things. Okay, so these are then social security number, telephone number, all of them fall under the identifiers. Okay, with one or more of these, you can actually pinpoint a person down. So now let's talk about the types of entities we are. We have two different types of entities. We have covered entities that fall within the circle of providing direct care. And then we have business associates who fall outside the circle of direct care. They help make the care better, but they're not directly involved in it. So who's a covered entity? It could be a healthcare provider, a health plan, or a healthcare clearinghouse. Under healthcare providers, of course, we, dentists, a dental clinic, a dentist with a specialty referral clinics, dental labs, medical doctor's office where we send, what they call medical clearance for, a hospital system, or a pharmacy. All of these fall under healthcare providers. Then you have the health plan, which manages the financing of your care, of your patient's care, and reimbursing you the costs and so on. So it's a health insurance company. It could be a company-funded health plan. It could be Medicare, Medicaid, a VA health plan, or TRICARE. They all fall under the health plan. The third one is a healthcare clearinghouse, where they process non-standard information. For example, you have a different form where you collect all the information. Then you want to send it to a health insurance company. But the format is different. So you send it through a healthcare clearinghouse where they'll put all the levels of information into a common format where the health plan can actually read and then reimburse you based on that. So all these entities fall under covered entity. So here are the list of covered entities we talked about. What or who is a business associate? It's a person or an entity or a company performing certain activities or tasks involving the use of or disclosure of PHI on behalf of a covered entity. Okay, these covered entities and business associates must have a BA contract. Like, for example, if you're doing repeated referrals to an oral surgeon's office, who is another covered entity, it's a good idea and a requirement to have a covered entity agreement, which says that they will treat your patient's information with the same respect and blah, blah, blah. It's a legal document. You have to sign it. You have it with Dentrix, you have it with Open Dental and all this stuff. If you're going to deal with a business associate, let's say for like a collection agency, you must have a business associate agreement. Don't look for these templates on Facebook or Instagram. Talk to a lawyer, talk to a law clerk, get them to write those things. Yes, initially they will cost a couple of $100 a pop, but it protects you well. An agreement has got the introduction, the preambles, the content, and the outcome and how to walk out of all those things. So they are legal documents. Don't ask, hey, do you have a template? Can you have it on Facebook? Anybody have it? I see this all the time. Don't do that. This is a profession. It's not a business. Dentistry is a profession. There are rules that professionals have to follow. Okay. If it's a business like, a bakery or something, there's no ethical issues or HIPAA issues. All you need to do is worry about not letting out that person's credit card information go wild. Okay? The BAs must comply with HIPAA privacy and security provisions of the High-Tech Act of 2008. Okay? So what is the privacy rule? Privacy rule helps protect the health information that is used and shared by covered entities during provision of care. It also extends to the business associates who help covered entities carry out other supportive functions. See, I'm building this like a story, I mean, this is dry stuff, but listen out to this overview like a story. Okay? Whenever we need to share this information, it should be for a particular meaningful use. It is towards taking care of the patients and the patient care activities. Okay? You do not initially, for normal patient care activities, if you get a signature from the patient that the patient is okay for the disclosures for his or her care, you don't need to keep repeatedly getting a clearance from the patient. You can, go ahead once you get your clearance, and then you order refer this patient to an oral surgeon. You tell the patient, I'm going to refer you to the oral surgeon. I'm going to send all your information which is needed, and you can send it. You don't need to get another signature. Now, on the other hand, if you want to use that patient's teeth, pictures of the patient's teeth or the face, or any other information for non-treatment care, but for advertising for your clinic, you must have a separate agreement for that. Okay. So you should get a separate authorization from the patient, and you got to talk about the scope, what you can use it for, what are you going to use it for, and at any given time, the patient can pull that down as well. Okay, they have the rights to do that. Only share the minimum amount of information, when you need to do the referrals to other covered entities or business associates. Covered entities are required to disclose PHI to the patient upon patient's request within 30 days, according to the federal government, but within 15 days in the state of Texas. They are required to disclose PHI to law enforcement upon request. Okay, in cases like abuse, child abuse, spouse abuse, elderly abuse, and so on. These requests could be from law enforcement, okay, or through a subpoena, from a court. A trained privacy person in-house who is responsible for keeping track of disclosures is a must. There has to be a designated HIPAA person. They also develop and implement policies for the clinic, which is very different from one clinic to the other. This person is also responsible for receiving complaints. It could be your office manager, it could be you as a dentist. The privacy policy is shared with the patient. You give them a copy, of course, you always do. And there should be a notice of privacy policy prominently located and visible to the patients in the clinic. Have a plaque at the front desk itself with a HIPAA policy. You can get a template of that from the federal website where there is this hyperlink. Okay? Now, the privacy rule is mainly concerning digital transfer, protecting digital transfer of protected health information. Then you have the security rule where you protect it digitally and physically as well, within and outside the clinic. The security rule requires covered entities and business associates to maintain reasonable and appropriate administrative, technical, and physical safeguards for protecting ePHI or even physical PHI, which you've kind of printed out and is still in process. The covered entities must ensure the confidentiality, integrity, and availability of all ePHI they create, receive, maintain, or transmit, or if they have to make any modifications within that system, there should be a tracking out there too. They should identify and protect against reasonably anticipated threats to the security or integrity of the information. For example, what do you call reasonably anticipated threats? You don't leave a patient's information lying around, in the clinic overnight. You got to put it away. Once you used it, immediately try and put it away. You can't keep the screens open with patient's information out there so others can read it. Okay? That's another simple example. You cannot write down a patient's name and credit card number and stick it to the bottom of your computer screen to enter it into the information later. Okay? You can't leave stuff in the fax machine or the printer and then leave for the day. You cannot, leave for lunch or something without logging yourself out of a system. All those things are reasonably anticipated areas where there could be a breach. The other thing is maintaining the security of your network systems. Who maintains your network system? Ask them on a periodic basis. How have you challenged your system against a breach? They have to give you a report. Ask them to send you a report. File all those into your system and keep them. Do a walkthrough once every 6 months at least, along with your team, to see how you can physically and digitally protect health information. Okay. Then, if you make by mistake you refer it to information to a different person, not the person you were planning to, what measures can you take to mitigate that? Can you call them and tell them, please delete everything? Do that and make a record of that. Okay? Ensure compliance by the workforce. Do not let somebody log into a system with somebody else's password and so on. I mean, that's a common thing that happens. Okay? Make sure that everybody logs out when they leave. Make sure that they don't leave patient information lying around. You have to haul them up if they make these things repeatedly, and you must punish them. That's a requirement, actually. There should be a penal angle to it. Well, you did this, now you're going to lose privileges for blah, blah, blah. Okay? HIPAA, the Office of Civil Rights, Health and Human Services, does not look at, oh, it's just a small office, let them go. No. Oh, it's a big office, we need to nail them. They look at every small and large offices like with the same lens. Okay. What they say is the measures you take to protect the information is scalable. For a small clinic, it may cost you more. For a large entity, it may cost you less per patient, but you got to do it. It also addresses risk assessment and administrative safeguards within the clinic. That means doing your due diligence of a walkthrough and so on. So what are the physical safeguards? You must limit access to only those authorized access, who are authorized the access. For example, your hygienist, let's say, cannot access all other patient records that she's not been assigned to digitally. Same thing applies to an associate. What cases the associate is actively treating are the cases that belong to the associate, and they can look into that information. They cannot snoop around and look at any other patient's information without any valid meaning. It has to be meaningful use. Okay. You must implement policies and procedures of use and access to workstations. Each person has to have their own login credentials, password, and they must be repeatedly, every so often, every month or 2 months or 3 months, you have to keep changing them. Okay. You're not supposed to share passwords. Okay. You should also have controls on electronic media, the transfer, removal, disposal, reuse of electronic media for EPHI. Anything you do has to have a log built in to detect the time, date, and person and what the changes they made. Then you have technical safeguards. You must implement policies and procedures that only allow authorized persons to access the EPHI. You must implement hardware, software, procedural mechanisms to record and examine access and other activity in the information systems that have EPHI. For example, if you want to go and modify a patient's information, there has to be a log of that. And it should be true modification. You can't just cook up something and put it in. Okay. You should ensure that EPHI is not improperly altered or destroyed. You have to have electronic measures in it. For example, you want to kick a patient out from your care. I've seen people saying that this person behaved badly. That's okay. But if they still keep adding their opinions instead of actual facts, that itself is a violation. Okay. So another thing is, when you want to get rid of your hardware, you have to scrub the whole thing out, and the whole thing should be destroyed after making a usable copy in a different new system. All those things must be recorded too. Okay. So you should protect both physically and digitally the information according to technical safeguards. What is HITECH Act? HITECH Act is Health Information Technology for Economic and Clinical Health. It expands HIPAA's privacy rule, expands the security rule, protects patient health information, increases patients' rights in complaining and accessing their records or modification of the records thereof, protects unauthorized and commercial use of EPHI or PHI, mandates breach notifications to the Office of Civil Rights. 15 years ago, hardly anybody complained or filed information that they had a breach. After 2008, it became mandatory, and they'll come after you if you don't do that. Okay. I've actually served on a couple of cases. Not a nice feeling. It's much more tougher than OSHA, because OSHA is about 4 times cheaper than HIPAA on fines. Then requires business associates and covered entities both to implement effective information security programs. Okay. So the types of PHI could be electronic, spoken, written, or heard. It could be billing information, chief complaint, diagnosis, allergies, alerts, observations, medical and dental history, medications taken, pretty much the whole record, if you think about it, and follow-up information. You have to protect every single item of this. If patient requests information in writing, within 30 days, in all 49 states other than Texas, you must provide that information. In Texas, within 15 days. Okay. You must provide that information in an electronic format until and unless the patient requires it in other formats. This is one thing which I've seen so much of abuse in private practice. Okay. When I was covering the clinics, I used to see 40 or 50 patients a day. Diagnostic sciences, we see from screening to treatment planning to closing patients out. Okay. Let's say an example is a patient walks in, for screening, and we ask the patient, have you been to a dentist recently? They say, yeah, last week I was there at my dentist. Then we ask them, do you have your x-rays, which they took, a full mouth series or a panoramic or a specific, object-oriented x-ray, like a PA of, third molar or something like that. They'll say, yeah. So according to ALARA, we try to reduce exposure. We try to get that data or the radiology images, the radiographs digitally, so that we can use it to treat the patient. So we fax the clinic the information that we request. And you know what? I've seen people taking a screenshot of the X-ray on their screen with their phones and then emailing it to the school. I've seen people printing out the thing on a sheet, scanning on a white paper, scanning it and sending it to us. That doesn't go in, conform with, my packs and stuff where you can pull it out. They have to send it in a usable digital format. At times I felt like, actually calling the clinic and telling them that I'll complain to OCR. But, when everybody's doing, a lot of them are doing this thing, it's not my fight. You must provide it in a usable format. Even if you take a CBCT, you must provide it in a usable format where I can use it, you know, in my digital systems. Okay? You're not required to provide access to a person's PHI that is accepted. That means there are very rare cases where you cannot provide the patient's PHI on request, where it is a threat to life for the patient or anybody else. And those are very, very limited and rare. I've hardly come across one. Another thing is, you're not supposed to charge an arm and a leg for giving them their copy. Yeah, it is the patient's record which you have generated, synthesized, and written a whole bunch, but still it's the information of the patient. They have absolute rights. Just because you took a CBCT which you could bill for about 250 or 300 bucks, you can't charge them that. All you can charge is a transmissible cost, like copying cost. You can charge them 25 bucks max if you want to. Okay? Then there's a rule called the need to know rule. Only those directly involved with individual patients need to know the patient's protected health information. It has a bearing on access to all records by all employees or entities. Care providers can share the treatment information for appropriate and meaningful care of patients. Let's say I send patient A to Jorge Gonzalez, a good buddy of mine, a maxillofacial prosthodontist who practices in Fort Worth. He does a lot of anaplastology as well. All I do is I send the patient information, which is the medical history, a summary, the dental history, what the patient needs, and what meaningful x-rays or CBCT I have, and what I plan to do if I want him to do. Okay. I don't send the whole record or give him access to the complete record. If he wants to generate more information, he can ask that patient. They will sign a HIPAA form. They will build up the case out there. Okay. Then, so that is the amount of information has to be minimal. You got to use your professional judgment out there. Don't share unnecessary information, okay, with consultants or covered entities. So all people involved in care do not need to know everything, but only should know what is meant for treating the patient. Access only those records of patients that are assigned to you. If the patient is not yours, then do not try to access the information. I have seen or heard of a bunch of complaints. See, I do in-office training till COVID happened, and now I do it on Zoom. But one of the things which is consistently being abused is forms of financing of the patient care. I'll give you an example, care credit, okay, or there are multiple of those. I'm not picking on any one or the other because it's not their fault. So let's say patient A needs a 6-unit bridge running from 6 to 11. Patient doesn't have the hard cash to pay it. Patient also needs number 19 and number 30 to undergo root canal and a crown, or possibly an implant. But the patient wants, the upper anterior fixed first because they want to go back to work and do stuff. Patient has a decent amount of credit history. Okay, may not have money, but the credit history is good. So you refer them to items like care credit or something. If you charge about 8,000 bucks or 6,000 bucks for the 6-unit bridge, for the upper, But the patient, based on the credit history, has been cleared about 12,000 or 14,000. Clinics have looked into that and then bumped up the treatment plan and sold it to the patient, saying that it's a must after providing an initial treatment plan. That is not only a violation of HIPAA, it also can amount to fraud. Okay? And these are not a once in a way complaint. I've seen people who have left a clinic and said in their previous clinic they don't want to mention this is what happened. Don't do that. If you have a treatment plan, talk about the treatment plan. Tell the patient this is what it's going to cost. This is how much care credit may give you. If there's any additional stuff, we will discuss that later, but we're not going to bump up the cost based on how much credit you have. If the patient is not yours, then don't try to access the information. That's what I'm saying. Or even if it is yours, don't delve into unnecessary financial information gathering to buck up your treatment plan. Don't do that. Okay. What is a breach notification rule? The definition is impermissible use or disclosure of PHI under compromising the security or the privacy rule. So if you either compromise the privacy rule or the security rule, then it possibly is a breach. In the event of a breach, the rule requires the covered entities and business associates to provide notification of the unsecured PHI or PHIs of multiple patients. The FTC, Federal Trade Commission, enforces the same to vendors of personal health information or the records companies or third-party service providers. According to HIPAA, it is always presumed to be a breach. That means you're always guilty that a breach has occurred until and unless you can prove otherwise. That means if they come knocking on your door and they say, show us the proof that you do not have any breach, you got to show them that to a reasonable extent that there wasn't a breach. So everybody is a suspect in this issue. Okay? The only way you can show them that the breach has not occurred or possibly not occurred is by doing a periodic risk assessment within your clinic. Okay? So we'll talk about those variables also. Fines. This is a biggie. If you did not know that the breach occurred and you got to know later, each violation per case can run from $100 to $50,000 with a maximum of $1.5 million for the complete breach. All the way, look at this. Willful neglect. It starts off $50,000 per case breached, all the way to $1.5 million. Now, above and beyond this, I mean, these are actually the costs of the fines which they will levy on you. In Texas, you can add another $250,000 on top of that $1.5 million. So it'll be $1.75 million if you get stuck. And these are fines. Apart from that, the costs of managing this issue. What about civil suits, lawyers' fees, representation? All these things can happen. Okay. So we talked about this permissible, transmissible fees. Training required. When you have a new employee come in within 90 days in the 49 states of the United States, you have to train the person within 90 days. In Texas, it is 60 days. You have to repeat it, and at least every 2 years, you have to repeat the training. If you think OSHA is bad in the number of hours you need to actually understand OSHA, HIPAA takes about 21 hours of actual classroom sessions. I would tell you, don't do it once in 2 years. Do it every year. Every year, learn something new within HIPAA. Okay? OSHA is required every year. HIPAA is required once in 2 years. Just go ahead and do both together every year and learn something new. Okay? You must have a signed attendance log to be maintained. Okay? So, simple do's and don'ts. You can incorporate this into your own audits, like your walkthroughs. Avoid unnecessary discussion and gossip. Return patient information back to storage. Close the door and keep the voice low. Do not announce loudly. Flip over the patient's chart so that nobody else can see it. Same thing with the computer screen. Use a screen protector. Okay? Wear name tags or IDs. In a large institution, you don't know who's who. So if there's a person without an ID, it's a bad thing. Don't take information out of the clinic either on your laptop or on your cell phone or on a thumb drive. It all has to be within the clinic system. Do not use unencrypted mobile devices to use PHI. Do not email information unless encrypted, or use an encrypted platform to share your information. Those things cost about 50 or 60 bucks a month, but it's worth the trouble. Okay? Do not leave PHI in the printer or on a fax machine. Use secure access to computer, email, and internet. Okay? And update the security software as required. Your experts who set up your system will tell you when to do it. Do not use internet access in open public places to view PHI. Okay? Don't go to Starbucks and then log into your system from there and then try doing it. There's a very good possibility that somebody will be hacking into you. Lock and key approach for most of the items. Internet and digital security. Do not share passwords. If somebody wants to access, a Wi-Fi in your clinic, have a separate Wi-Fi away from your own internal systems Wi-Fi. These are some of these things. Then financial information. Do not write a check. Do not write checks, numbers, and credit card numbers on sticky notes and stick it onto your bottom of your computer screen. I see that happening. So here are some of these things on financial info. Some of them on health info. Some of them on personal info. Lock and key approach methods. All these can be variables in your own internal audits, which can possibly tell HIPAA when they come knocking on your door, we did all these things, and we feel reasonably comfortable that we may not have had a breach. What HIPAA does, or the Office of Civil Rights does, is they don't want to take a stick and chase everybody. Okay? It's a lot of work for them to come to your clinic as well. What they want you to show is good faith efforts, which takes you a long way. So have all these things, make a form within your clinic, put your clinic's name up, put the doctor's name, put the name of the HIPAA person, responsible. Write down all these variables and put a check mark. Do it twice a year. Have a 15-minute meeting. Record all the notes for the meeting. File it away. You'll do 100% better job than most clinics I've visited in my life. Okay, here are some of the information variables you can use for your audits. Patient health information. Okay. Lock and key measures. At the end of the day, make sure that nothing of patient information is open to the people who come to clean your clinic later in the evening. Okay. Lock and key approach. Put them into a cabinet with a lock, a small lock, even a $10 lock is good. Lock that is a deterrent. If a person wants to really break in, they will break in. But if there is at least a lock, you've shown good faith efforts that you are protecting it. Okay? Do a walkthrough of your clinic from end to end. Okay? Here's an example. I walk into my friend's clinic, and this dentist is my dentist as well. Okay? And my family dentist. Walk into the clinic. The first thing I see is, wow, these are active patient records in process. I can actually pick them up and walk out of the clinic. You see, if I just want for the dentist. Here is a point of sale machine. Okay. Every time a person uses a credit card, make sure before the person leaves, stand up and see if the credit card has been taken by that person and put into their wallet. Don't let them leave without taking the credit card. A lot of older people, a lot of people who are busy end up leaving the credit card. Okay. The next person can actually steal that. That's financial information. Another thing is, from this angle, I cannot see what's on the screen. So use a screen protector out there. Don't leave all these paperwork at the end of the day. in your front office and leave for the day. Use a cross shredder. Anything which you've written down for temporary purposes on patient information, shred them. If a patient calls and wants to, make a payment, if you're on another call, you can put that other call on hold and enter the patient information directly into the record, the financial information or whatever it is. Or you can tell the patient, I'll call you back and please be ready. And then after you hung up with your call, you can call that patient back and then enter it directly into the financial records. Okay. Don't write it down on pieces of paper and leave it around. Those things cause issues. Never leave stuff on the fax machine. It should be empty like this. Okay. Here's the thing, consultation room. Before a patient comes in, make sure that previous patient's information is not there. Okay, they can't snoop around. Okay. Here, same thing. End of the day, make sure that everything is done. Here, I can read half the things on the screen. Okay. Use a screen protector out there for this one. Here, end of the day, no patient material again. You should all go into some kind of a lock and key approach. You want to leave for lunch, log out of your system. When you come back, log back into your system. Okay. Shut the door when you're doing a consult, if you have a door, or keep your voice low. Okay. When the patient leaves, take the patient's information, file it away, and keep it ready for the next patient. Okay. So these are some of the things. Like here are the privacy filters. Of course, Amazon will make money out of it, but it's a good idea. So here are some of the variables which you may want to consider in your walkthrough or within your policies. Okay. So now, one of the common things I see complaints from specialists is that a general dentist sends an email with a patient's not non-de-identified x-rays. You can see the patient's name on the thing and record number by regular Gmail. Don't do that. Even if you have G Suite, you have to talk to the representative of G Suite to see if it is HIPAA compliant and everything is encrypted from end to end. Most of them are not. Okay, they're under, most of these clinics who think they have G Suite, they're under the false pretense that, oh, we're protected. No, you're not. Okay. An end-to-end encryption platform is when you are planning to share information, you will send an email. They will have to log into your system with their email. And then it goes end-to-end encrypted. They can then access the records which you want to share with them. A lot of people complain also, oh, I have to do this extra step. Well, you can tell that high-end mighty specialist you're sending this thing to. If you don't want to, I'll take my business elsewhere, but this is what is required because I have to protect my patient's information. And I want to protect my patient's information when he becomes or she becomes your patient too. It takes another 10 or 15 seconds. Do it. If you don't have a system like that, then use an use an encryption software like AxScript or something, where you can encrypt the file, send the file by regular mail, and then call them and give them a code how to open the file up. That's another way of doing it. That's legal. But it's a pain because it takes a lot more time doing that. Okay. Make sure your software is all up to date. Now, here is an example of a platform which was developed by Dr. Kandru. He's an endodontist and he practices in a couple of practices in Boston, Massachusetts. He and his team actually developed a referral platform, okay, where you can actually send small files to multiple CBCTs. You can have a video conference and everything, a clinical conference with the patient or with your lab or with the specialist, okay? And it's all encrypted and it's logged in, okay? And I think it's a subscription-based thing. Now, why I say try to use these kinds of softwares. I mean, I served as a consultant for free for a few months when they were developing that stuff. I have no stocks or shares or app options on this one, but this is possibly the only non-enterprise software in the US that is available. Okay, enterprise things, you know, like large for large entities like hospitals, they all have this thing built into it. But this is a standalone, which can be a plugin. It works with as a plugin in most of the dental EHRs, or it can be a standalone in a few other EHRs. So, for example, if I have to call a clinic and do a referral, I call a clinic. On the other end of the phone, Welcome back, guys. And this is the last presentation of today. One of the things which I prefer and the organizers want is all of you to send me and the organizers an email with any of your questions or concerns in infection control, OSHA, HIPAA, and especially SARS-CoV-2. Okay? Because if you give us a feedback, we can actually make the programs better. We can answer your questions. So between now, whenever you can email me at drpattaya@tutce.com, or and also you can also email the organizers of this program as well. Okay, so I can reply back to everybody, and we'll have all the answers in a docket. Okay, so the next chapter or the topic is OSHA's Hazard Communication Program, which is 29 CFR 1910.1200, of 2012. This one includes the United Nations Globally Harmonized Systems of Classification and Labeling of Chemicals, GHS, and GHS revision point 4. Okay, so let's talk a little bit about this. Most of the people in dentistry don't know how to handle chemicals or know much about this topic, but it's a required topic. So the purpose of the Hazard Communications Program on chemicals in the workplace was to ensure that workers recognize and understand the dangers posed by hazardous chemicals in dentistry, okay? And take the necessary safety measures to avoid harm to themselves and their co-workers. Okay? So the questions are, which of the chemicals we use in dentistry are hazardous chemicals? What are the hazards from those chemicals? What are the protective measures to be taken, while receiving the chemicals, while storing the chemicals, while mixing them or using them, and in case of a spill, how do you clean it up? What are the precautionary measures and information to be shared, such as labeling, safety data sheets, use of personal protective equipment while handling them, and what are the training needs in handling chemicals? So it was developed in 1983 by OSHA as 29 CFR 1910.1200. Okay. Now, the story goes like this. The US and certain other medically advanced countries had fairly strict rules on how you handle chemicals, okay, in the workplace. The same thing did not translate to the other countries in the world, over 200 odd countries. You see? So each country, like the US, had different standards and different labeling systems. Canada had different labeling systems. Both of them spoke English, at least English was a common language. Then you have Mexico and other South American countries which have Spanish and Portuguese, and they have a different labeling system. So it was a mishmash of standards across the globe. In India, it had different standards. For example, if I had to ship, let's say, EDTA from Bangalore, India, I had to get a clearance for manufacturing, getting the labeling done for India, and labeling done for transportation on the road to a port, let's say Mumbai or Bombay. And the port authority has got their own standards. So 5 sheets become 300 sheets by the time it hits Mumbai. Okay? And it has to be in English, Hindi, and the local languages. It goes to the states within India. From there, let's say it goes to Dubai. There it has to be in Arabic and English. And they have to follow the standards out there, and then you have other forms to fill. From there, let's say it goes to Rotterdam, and then it comes to the port in New York. your 5 sheets would have become 500 sheets of clearances. And the labelings will be all over in different languages. So what OSHA and the United Nations did was they got together and they said, let's make this thing simple where people from every country can understand without too much of change. Instead of using a labeling system or types of numbering or color coding and chemicals and languages, let's go into developing pictures which approximate what the danger is. For example, an oxidizer is one which will help a flame, expand. So O, think about this. O with a flame on top of it is an oxidizer. Now this is flammable. It's just a flame on a flat surface. That means these chemicals can just catch fire. Then here's an exploding bomb, an explosive. This can be self-reactive, or it could be an organic monoxide, and if the conditions are not met of stability, it can explode. And then you have a picture, of a human being-like thing with a starfish-like object right on the chest, on the body. That means it's a health hazard. Okay? So they developed this in 2012 and implemented it in the US in 2012. And other countries had either done it slightly before. Now, close to about 200 countries follow the same labeling system of chemicals. Okay? And it is called the globally harmonized system. So why use the GHS? We get chemicals from all over the world. We send chemicals all over the world. Different countries have different standards. Different occupations and industries have different standards. The handlers have communication barriers and languages and different educational levels. In dentistry, we might not even find a college graduate who's doing a dental assistant's job. A college graduate would have a lot more understanding of chemistry and so on than a 12th grade person. So it has to be so simple. We have in Texas, we have people who speak Spanish much better than they speak English. We have people who speak Vietnamese or Hindi or Gujarati, much better than they can speak English. But all of them have, if they want to have a job in dentistry as a dental assistant, they have to understand these things. So the barriers have to be broken. And that is why GHS was formed. Pictures or cartoon-like pictures are easier to identify and understand than color-coded labels and numeric stuff. It makes the world a better place. So in the US, it was supposed to be implemented by 2013, for sure. Okay. By 2016, all the manufacturers should have made secondary labels. Suppose I get a bulk of chemical, I have to put it into a different bottle, which is not provided by the manufacturer. I have to put a secondary label. So that said that all manufacturers should have these labels ready by 2016 or so, but I don't see that happening yet. But there are blank labels which you can affix to a secondary container and fill in the spots. For that, you have to understand what the safety data sheet says. So here there is a law called Right to Know law and Right to Understand. All employees have the right to know and the rights to understand the hazards posed by chemicals in the workplace. They must learn to use protective measures to reduce risks of being exposed. All employees must be provided adequate information and training and documentation of the training in handling chemicals. All employees must understand the information on the chemical containers, the labels, the use of safety data sheets, and the written hazard communications program. Every clinic should have a written hazard communication program according to OSHA. Okay. So what are the steps in implementing the hazard communication program? One, learn the standard and identify the responsible staff member. Just like in HIPAA, we had a HIPAA responsible person in the clinic. You have to have an OSHA responsible person in the clinic too, who has to take helm of handling all the safety precautions for chemicals. Okay? Then you must prepare and implement a written hazard communication program. Most of the people buy a manual which has got bloodborne pathogens, chemical safety, and so on. You must prepare a written plan to indicate how the hazard communication will be addressed within your clinic. Okay? You must have an inventory of all the safety data sheets of all chemicals that come in. And you should actually, let all employees have access to it. It should be documented. It should be in a folder, alphabetized or categorized based on what the plan you use in your clinic. You should use labels or other forms of warning, okay, on the bottles or the containers which contain these chemicals. Then ensure that the containers are labeled, the secondary containers are labeled appropriately. Okay? Maintain safety data sheets of every single, including even if you get sterile water, you have to maintain the safety data sheet that comes with the sterile water package. Inform and train the employees. Every year you have to train them and update training once a year, okay, on hazard communications. Evaluate and reassess your program annually. If you have new chemicals that come in, you have to train the employees immediately and add it into your training program thereafter on an annual basis. Okay? So, what are the risks epidemiologically? What is the evidence-based information we need to understand as to why we need to implement this program? Well, within the US, there are over 250,000 registered chemicals. About 1 million tons are produced annually and shipped all over the US. They include acids, alkalis, adhesives, solvents, pesticides, mixtures, germicides, and paints, and so on. These chemicals also, apart from having their own function of use, they also have adverse effects on health, leads to hazards such as sensitization, irritation, cancers, allergies, injuries, death, burns, and so on. And these issues can be long-standing for the rest of your life if you don't die initially. They could be acute or chronic, or it could be an acute exacerbation of a chronic condition caused by these chemicals and lead to death. 1 out of every 4 workers in the US is going to be exposed to a chemical. That is the rate of exposure over their lifetime. Okay? So, we know all the types of chemicals. They can, the toxic chemicals can cause death. It can affect different, systems in the body. It can be hepatotoxic, neurotoxic, nephrotoxic, toxic to the hemopoietic systems. It could be irritant sensitizers. It could injure the mucosa and eyes and skin. Okay. So read your labels on any chemical you get. Read the labels. Read the warnings. It's very important. Okay. What should the training include? It should include measures to detect the presence or release of chemicals in the work area. That is done through monitoring. What does monitoring contain? You look. You find out if there are any malodors or odors being emitted by the chemical. Do the visual check as well. Do you have adequate measures to control the spread of the chemical in the workplace? What are your protective measures and measures in case of an exposure? What are the types of PPE you use? Do you understand the safety data sheet of the chemical in case you need to refer to it for first aid and stuff like that? what are the specific short-term and long-term effects of that chemical? You know, what is your facility's policy on reproductive toxicity? One of the most common questions I get on chemicals is nitrous oxide. They say, oh, we have a bunch of people who are of childbearing age, and what is the policy on that? You have to fall back on the chemical, fall back on the MSDS or the safety data sheet, and implement those things within your protocols. Then, let's say, before 2012, we used to label secondary containers. I ran a lab as well, a research lab. I was a full-time clinician in the clinic. I spent, 4 days in the clinic and most of the weekend and the other day in my lab, testing different devices, different chemicals, different germicides, and so on, right from impression materials to standardized tests to bonding and shear bond strengths to testing germicides, testing the corrosive effects, and so on. Yeah. So I had a whole slew of chemicals. I had people in the lab working. Most of them were dental students. I had to train them in lab safety. I had to train them in chemical safety. So we used to use the NFPA, National Fire Protection Agency's labeling system for secondary chemicals. Let's say I order something from Fisher Scientific. They send it in a bottle. I have to make a mixture of it and put it into a different bottle for use. So the secondary bottle which I put in has to have the chemical label. So we used to use this diamond-shaped label with these 4 different colors and numerical systems. Okay. We had to put the name of the chemical and expiration date of the mixture, name and address of the company, and the 800 number to call. Okay. This is what we used. Okay. Oh, the blue-colored part of the label is health, red is flammability, yellow is reactivity of the chemical, the nature of the chemical. Then white are specific hazards. So the blue, the red, and the yellow have got a numerical system from 0 to 4. 0 means it's not hazardous. 4 is extremely dangerous. Okay? How do you enter that number? You have to read the safety data sheet of the chemical. Now, if it's a water hazard, if it's a radiation hazard, you've got to put the radiation label on it as well in the white slot of the diamond-shaped label. Okay? There you go. Then we take this part of and we stick it on to the secondary container. Here, on health hazard, it only gets a 1. On fire hazard, it gets a 3. That is, it's pretty dangerous. On reactivity, it is fairly dangerous because it gets a 2. It's not a 1 or a 0. And it is radioactive. So based on these, we have to take precautionary measures of using PPE. How long can we be exposed? Do we have to have a radiation badge? And all these things come into play. But if a new person who does not understand this labeling system starts handling this chemical based on this label, it's not nice. So that's why when we shift over to the globally harmonized systems where we have pictures of hazards, which are referred to as pictograms, okay? They divided the hazards into physical hazards and health hazards. Physical hazards is how you can get injured. Health hazards is how it can affect your health. Okay? 2 different things. Under the physical things, you have corrosive nature of the chemical, flammability, combustibility, hazards of compressed gas, explosive nature of the chemicals, depicted by all these pictures here. Under health hazards, irritation, rashes, allergies, burns, all those things fall under exclamation mark. Acute and chronic toxicity of the chemical here. Skull and crossbones, CNS effects, liver, kidney, cardiovascular, lung problems, miscarriage, sterility, carcinogenic effects. falls under this thing, this dark human being kind of a thing, with a starfish, white starfish on the chest. That means it's systemic. Then you have environmental effects for disposal, which is depicted by a dead tree and a dead fish. So simple. These few chemicals can actually make out. So health hazards. As I said, person with a starfish on the chest. Simple. Carcinogens, all these things. Flame over a flat surface, it means it's flammable, it's pyrophoric, self-heating, emits flames and gases, self-reactive, it could be an organic peroxide. The exclamation mark, would be irritant, skin sensitizer, acute and chronic, acute toxicity, narcotic effects, respiratory tract irritation, hazardous to ozone layer, so on. The gas cylinder means gas under pressure. So if you drop the gas cylinder, the neck breaks, it can shoot out like a missile and kill people. Then you have two test tubes, one falling on a flat surface and one falling on the hand. That means hand is corrosive, it causes skin burns or damage, eye damage, and on the flat surface, that means it's corrosive to metals. Then you have exploding bomb. It's an explosive, self-reactive, organic peroxide. Flame over a circle, it's an oxidizer. And toxicity again, see? Dead tree, dead fish. Skull and crossbones, acute toxicity. Okay? So, within the label, the new label, it should, apart from these pictograms, it should have a signal word which says warning or danger. It should have a hazard statement, a precautionary statement, okay, so on. So, if a manufacturer provided a secondary label, let's say you buy a bunch of N-propyl alcohol from a company. Okay, they send you a huge carboy of it, and then you have to put it into different bottles. Okay, so they will, if they have a label, this is how their label would look. It will have, number one, the product identifier, which means N-propyl alcohol. Then a signal word, whether it's danger or warning. Danger is more dangerous than warning, right? Yeah. Then the third one would be a hazard statement, which says it's a highly flammable liquid and vapor. It causes serious eye damage, may cause drowsiness and dizziness. That means you could fall. Yeah. Then you have a precautionary statement, which says how you handle the chemical, how you store it. Keep away from sparks, open flame, heat, and so on. No smoking close to the chemical. Breathing the fumes of the chemical, the vapors or spray. Wear protective gloves, protective clothing, eye protection, face protection. Now, here you can use a chemical mask as well so that you don't breathe too much of it. Okay? Then it also tells you what to do in case it falls into your eyes. It says if in the eyes, rinse cautiously in water for several minutes, remove the contact lenses if present, and continue rinsing. Then the fifth one is a supplier identification, which says Acme Chemical, 711 Roadrunner Street, Chicago, Illinois, blah, 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 and it gives you an 800 number or a toll-free number. The last one are the pictures, the pictogram. It's a graphic symbols intended to convey specific hazards and information visually. So it is an irritant and a corrosive item. It is flammable, and it can cause drowsiness and dizziness and so on, okay, based on these three pictograms. Okay. Now, since most of the chemical manufacturers still don't have the specific secondary labels, what the industry came up with, blank labels, which you can populate. So here's the thing, here you can put in, the alcohol's name, N-propyl alcohol, whether it's a danger or warning based on the safety data sheet. Health hazards, you can check it's an irritant, you can check this box. You can check it's a corrosive nature and a skin irritant, you can check this box. And it's alcohol, it's flammable, you can check this box. Okay. Then you can also here for personal protective equipment, you can say use your gloves, because it is an irritant. You can use a mask. You can use your gown and eyewear. Okay? Then you can put the reference of the safety data sheet out here, the name of the company, the 1-800 number. There you go. And then you slap this label, which you've developed, onto a ball, or onto the next bottle. Okay? So what I would advise for you guys to do is take any safety data sheet which comes with any chemical, read it from end to end and understand what it is. Okay? And then get an empty label and try to populate a chemical's information. So where do you need to put these labels? For example, a simple example is the ultrasonic bath. It has got a since you're putting dirty instruments with blood and everything, it has to have a biohazard label. And since it has ultrasonic solution, you have to put the chemical labels in it, onto it. Okay? So read the ultrasonic solutions safety data sheet and populate this empty label and slap it on it. There you go. Okay. Well, I think we are done with all our 4 hours of training, the mandatory or the essential training for your license renewal. So what I would say is the chapter COVID and the infection control would be 2 hours on infection control. Then you have an hour on HIPAA, an hour on OSHA. Okay. Again, guys, don't forget visiting ToothCE LLC or www.toothce.com. If you have any questions, okay, I want you to email me at drpattaya@toothce.com. You can also send the same questions to the organizers. We will compile the whole thing and I'll list out the items. Okay? So if you want your office to be trained, either any individual or a whole group, we have really good discounts going on as of now at ToothCE LLC. So come on over, visit our site and enjoy. Okay? Thank you so much for this opportunity, Dr. Kianar Shah and AAOS. And thank you so much for the organizers and the supporting staff. Okay? Have a great day. Any questions, I'll hang on for another couple of minutes. Otherwise, have a great night and enjoy yourselves.